สวัสดีค่ะยินดีต้อนรับทุกท่านนะคะกลับเข้าสู่อาทิตย์สุดท้ายแล้วนะคะของ IAEA Expert Mission Strengthening Optimization in Radiological Practice นะคะเช่นเคยนะคะอาทิตย์นี้ก็ยังได้รับยังไง Pro and Cons แล้วก็เรื่องของ Radiation Dose เป็นยังไงบ้างนะคะ Good evening Sam Welcome to the last session the finale of the IAEA Expert Mission I cannot believe this is week 12 almost 4 months that we have done these things so far together, right? And as usual, so this week is like a wrap-up week. But before we go to the wrap-up, you're gonna give. I gave you some homework about the cone beam CT that I want to learn a little bit more. Like, what is the cone beam CT and how we get involved? What is like the clinical usefulness of the cone beam CT, radiation dose or image quality, just like some background and concept that we can learn about the cone beam CT. And next thing we're going to talk about the dose registration, dose index registration, how to start and how to interpret your data. And at the end, you're going to put like since like we talk a lot about your suggestion, you put a lot of comments on each modality that we talk about how we do the dose optimization, what should we do for the next step in terms of the dose registration or DRL and everything. So this week we're going to wrap up on those things. Then you're going to give us like a summary, the comments, and we're going to have more discussion with Dr. Panruethai, Dr. Jiraporn, and also Dr. Naparapong that he said he's going to come by us today. So we will see. So I give the stage for you.
Wonderful. Thank you. I'm glad to be here. It's I was just talking to Tanya before we started. It's amazing that it's been this long. Just every once a week, it doesn't feel like it's been a lot, but then when you look back at it, we've been doing it for 3 months.
Yes.
Yeah. In fact, 2 years ago, I was sitting here with you guys at the very end of my last time I was in Thailand, eating the best pad thai I've ever eaten in my life. I got to take it. Tanya and her mom took me out for some really good pad thai. So I miss being there with you guys. Thailand is such a beautiful, beautiful country.
Yeah.
And so hopefully I'll get to be back there next time. We can go get some more pad thai.
Yeah, sure.
All right. And so we had a last minute request, and I'm always excited to give requests because it's what you guys want to hear. So I love talking about things that you want to hear. And so we're going to talk not really in depth. We're going to just talk about cone beam CT that's used outside of traditional diagnostic radiology based CT. And so just very briefly, what is cone beam CT? So what we're very familiar with, of course, is traditional CT scanners. You have the fan angles, you have the wide detectors, and that goes kind of around the body as it spins around, but it's thin. It only normally covers maybe 4 centimeters. It could cover a little bit more, maybe 8 centimeters. Normally, it doesn't cover a lot. And so it has to spin fast, and then the body has to translate through the scanner so that we can scan a large area. But in a different type of approach called cone beam CT, now we're going to use a wide angle, and that is so that we can cover a large detector. And this is, of course, we use this in fluoroscopy where we have these flat panel detectors at the end of a C-arm. And we're also going to talk about dental today. And this idea here now is we can cover in one image, in one projection, a large field of view. And so the biggest difference here is, one, we cover a lot of anatomy in one spin. Now, of course, we can collimate, so we can always pick how much we cover, but we have a maximally large area. And two, the biggest difference is the patient does not translate. So here you can see this kind of spiraling effect right here. That's because when you have a small detector to cover a large area of the body, you have to push the patient through. But of course, in this situation, such as with a fluoro unit, the system will spin around the patient, but the patient will not move, and the machine will not move while you're acquiring the image. Now, if you want to do a cone beam of one location and then do a cone beam of another location, you acquire it, you reconstruct the image, you move the machine, and then you do it again. And so it's a multi-step process. So today we're going to talk about the two more common areas of cone beam CT application outside of quote unquote typical radiology. And the first one is dental. These cone beam CT scanners. They're dedicated. They're almost always found in dental clinics or units. And they're obviously, you can see it's a C-arm, very much like a fluoro system, where you have the detector on one side and the X-ray tube on the other, and the system can still spin around the body because of its geometry, and so we can get nice, good imaging of the face. And the other one, of course, as I introduced in the previous screen or slide, is used typically in interventional fluoroscopy. So now we're doing typical procedures such as stents, grafts, biopsies, maybe needle localizations. The most common are these C-arm units that are going to be mounted either to the ceiling or to the floor, and they'll be found in an interventional suite. A more recent development are these mobile C-arms that can also spin and create a cone beam CT. They're not as common. In fact, I don't know of many that are out. I don't even know if these are for sale yet, but they've been working on these for the last couple of years. And so probably very soon you'll be able to do cone beam CT in the OR or other surgical areas where you normally find mobile C-arms. But for the most part, we're going to talk today about the fluoro-based C-arm CBCTs that are found in interventional radiology. So let's start with dental. It's going to spin. The system itself will actually not go a full 360 around the body. It's going to go most of the way around. You need to acquire a minimum of 180 degrees. We've already talked about this when we talked about CT. And during this procedure, it's going to spin around your body, and it's going to it's going to collect enough data to create two types of images, a 2D image and a 3D image. And we'll define that. We typically use this type of machine when we're obviously trying to image the oral cavity, but more specifically, we want to try to get the entire oral cavity. Whereas in intraoral dental imaging, you can obviously focus in on a few teeth, but you have to take multiple bite wing images to get the whole mouth. And at no point where you get the entire mouth in one exposure. So in this system, we can do the entire face in one exposure. It will, depending on the position of the system and the angle, also collect some information about the neck, the ears, the nose, or more specifically, the sinus cavities, and the upper location, the upper portion of the throat. Typically, in dental, we use CBCT for implant planning. I should speak very specifically to the U.S. I read several papers, and I read a couple of different dental society, I guess you would call them white papers or policy papers, where they talked about where they recommend the use of CBCT. And probably the most common area, at least here in the United States, is for planning of dental implants. So if you're get all new teeth or get a new tooth placed in, or you're trying to restore a tooth that's been knocked out. In the past, it didn't really require it, but they've moved now such that they strongly recommend CBCT for all dental implant planning. Of course, you can use it for a lot of other reasons, such as visualization of abnormal teeth, the evaluation now, for example, of the jaw and the face, and cleft palate assessment. You could do it if you're planning for a root canal. And then obviously the typical things you would see on a normal intraoral will appear in this. You'll be able to see caries and other things. But obviously the geometry is different. And we'll talk a little bit about that in a moment. There's going to be, of course, probably the second most common use for this, I guess I should have put this on the list up a little higher, is when you have facial or dental trauma. And so you need to visualize the extent of the trauma with respect to the rest of the oral cavity. So as I mentioned, when this system spins around the face, it's going to acquire two types of images. The first option is a panoramic image. It's a two-dimensional image. It quite literally takes the three-dimensional image and it flattens it out into a two-dimensional image, as you can see here. So now you can see all the teeth in situ. You can also see the jawbone, obviously the maxillary, or some of the sinuses, and depending, you can see some of the ear canal and the throat. I just listed all that. The issue with this is when you take a three-dimensional object, an object that's in three-dimensional space, it's got an X, Y, and a Z coordinate system. And when you flatten it out into two dimensions, you lose spatial coordinate system. So if you want to know how far, the physical distance from, say, one tooth to the next, or you need to know a length, and so you need to make a physical measurement, you can't technically do it on the image itself because there is no way to know exactly how many millimeters the image presents, how the image presents in millimeters or centimeters, etc. And so the only way to do that is you actually have to place opaque markers. And if you place two opaque markers, say on the face, and you know the exact distance of those opaque markers, then you could measure those opaque markers in the panoramic image, and then you would have a coordinate system so that you could then make other quantitative measurements. See, the reality is that almost 85, so about over 83% of all panoramic images have errors that exceed a millimeter. In other words, there is some accuracy that you can get from this, but there's also some inaccuracy. And so if you're really wanting a quantitative image, panoramic images are limited. And then, of course, probably the other major the other major limiting factors are, depending on how you position the patient and the type of equipment you use, each machine is going to have subtle differences in its geometric differences, its distances, the way it angles its X-ray tube to the detector. All of these things are going to cause discrepancies in how the image appears. And that's why it's not very quantitative. Probably the other big one, and this graphic was a little bit out of order here, is the fact that when you look at the panoramic image, of course, you're getting a nice coronal view of the face, but you actually can't see down. So you can't get the buccolingual view. So you actually can't see like the crown or the top of the tooth. So that brings us to the other way we image with a CBCT dental system, and that's creating cross-sectional 3D images. So obviously for the same sweep, for the same acquisition, you will be able to also produce thin section images. Obviously, the main advantage of this is you get your reformats. You get your axials, your coronal, coronals and your sagittals. You will have a nice quantitative, because it's in since you preserve the three-dimensional volume, you know what the distances are. So you can actually quantitate the image. So if you have some kind of trauma and you need to make measurements and you need to know kind of precise locations and how big, say, a tumor is, or how big you know, how much trauma there was to the face or the jawbone, you can actually start making those measurements now. Because there's minimal distortions, and there's obviously this is sliced, so it's just like a normal CT scanner. It comes in image slices. You can sort through those, and you can go in and out of all those different sources. And so there's really no tissue anatomy that's superimposed over the other, like in a panoramic, which is just a two-dimensional image. So the question then is dosing. So we'll talk about this kind of in a couple steps, but generally speaking, dental CBCT, so the dental acquisition, is a lower dose than traditional CT. So if you go into, normal CT scanner in radiology and you do a maxillofacial scan or even just a more localized scan of the oral cavity, that scanner, the CT scanner, is going to produce a little bit more radiation. It needs to, obviously. The volumes are different. The geometries are different. That the scanner is so much bigger, it needs more dose to go all the way from the X-ray tube through the patient to the detector. Comparing that to the smaller system that quite literally just spins right around the head, because of the fact that the dental CBCT systems have closer geometry and they're smaller, they don't require as much MA. And so the dose to the patient can be a lot lower. That said, these dental CBCT units are more dose than an intraoral dental imaging exam will ever produce. So here are some numbers. These are numbers I actually went out and measured so that we could just kind of talk about them. So we're going to compare a digital intraoral. And I know there are film intraorals that are still being used quite extensively here in the US, and I know in Thailand and probably all over the world. Film intraoral is still a little higher dose than digital. So for what it's worth, I only had access to digital systems, so my measurements are going to be probably lower if all you use is film. But know that still film intraoral is lower dose than dental CBCT. So I just had to make that statement. So we're going to compare digital intraoral. We're going to compare a standard panoramic image. So it's a spin around the face, and then the image is then displayed in two-dimension or flat. Then there are more specialty imaging where you're actually doing a rotation around the face, but the axis of rotation isn't centered in the body. It's centered on either the left or right TMJ. So you're doing more of a jaw. Of course, you're looking at the hinge point of the jaw. And then what would it be for a three-dimensional tooth or three-dimensional acquisition of the face? So we have our typical dose metrics of air kerma. And then we also can make either the CAP or DAP measurement. So now that takes into account the air kerma times the area of the exposure. And then very specifically for the CBCT system that does three-dimension, those systems will oftentimes provide you a volume CTDI calculation, something that you could use in a small way to compare back to regular CT scanners. So looking at air kerma values, you can see that the digital intraoral is usually about 0.1 to 1.3. So that is pretty slow. The 0.1 is on the low end. 1.3 would be maybe if you're doing like a molar or just something that's more dense, so you just need a little bit more MA. Standard panoramic, once again, that just depends on the geometry and the size of the patient, but smaller patients, even the smaller patients that we image in our clinic, will get about 0.7. So nearly 7 times that of the smallest if you're doing like say an incisor or something for an intraoral. And then TMJs, they're low dose because they're focused. The system's offset and you're only imaging a small volume. And you can see that here with the CAP. Now, when you start to put this in kind of order, the digital intraorals, they'll scale somewhere between 3 to 33 milligray centimeters squared. So air kerma times area. Standard panoramic, now we're getting higher. I guess TMJs are lower. But when you compare the intraoral to the panoramic are higher. And then when you get to the actual cone beam, the 3D, because you need really good resolution and you're trying to get really good detail of the whole intraoral cavity, the dose is just going to be a little bit higher. And so it can get all the way up to a cap or a DAP of, say, 542. So obviously several magnitudes of order higher than just a standard intraoral exam. And then, of course, the volume CTDI. These values may seem high. 10 milligray for a CTDI vol is actually really high. But when you realize this is not patient dose, remember, volume CTDI is never patient dose. It's a machine output. So that machine output is to a 16 centimeter CTDI phantom. And so when you consider that, most face and brain protocols, so like a typical head CTDI is going to be in the 30s and the 40s. And a face is going to be usually somewhere in the teens, so maybe 15-ish to 20. And so when you consider what we're doing down here from 4 to 10, that's actually a pretty low number. All right. So let's also try to put this a little bit into perspective. Now, I know we don't use effective dose when we do diagnostic reference levels. So really what I'm trying to do is just talk about the previous screen were doses to machine. They were machine doses. They were machine output, stuff you can measure with an ion chamber. Now, how would you equate that to patient population dose or risk? So trying to put this into perspective for risk, a typical intraoral or a bite wing exam, we do a lot of these here in the US. There's just, there's about 300-400 million of us here in the US, and basically every person should, not everyone does, but everyone should get a set of intraoral or bite wing exam images every year. So there's not quite all of our population, but a good fair amount of our population get these every year. And so when you look at the standard circular collimation on the end of these intraoral systems, you're talking about 36 microsieverts. So it's about 3.5 days of average background. If you use a collimator, which I recommend, we are actually in the process of publishing a paper on this, talking about this, it reduces the dose substantially. Now you can see this individual holding the actual imaging plate. It could be either a piece of film or a digital like CR plate that is what is used for imaging bite wings. You can see that the collimator is made to be the same size as the detector. And that is why the dose in these rectangular collimations are only a fraction of the circular, because the dose that goes out of the tube onto the detector matches the detector. Whereas with the circular system, the detector is only actually about a third of the volume that you're covering. And so the whole reason that we use these large circular is so that you don't have to be very accurate where you place the X-ray tube when you're imaging in the teeth. And so with training and with some experience, when working with our dental hygienists and our dental technicians, the people that actually take the X-rays, they've gotten to be really good because there's ways to align it. There's tools that help you align it really easy. So you put the tube in and you can get it aligned properly, and you pull the trigger and there's not a lot of cut. With experience, there'll be no cut. So, or image cutting or loss of image. So that's something that we just always talk about. I always advocate, if you're trying to reduce dose, especially in an intraoral circumstance where most people get intraoral scans every year as part of their dental hygiene, you should try to make it as low as possible. And that's kind of the same concept as mammography. We recommend all women get it after a certain age. Well, if that's the case, then we should make it as low as possible to keep everyone as safe as possible. So how does a panoramic compare to that? Well, in the US, we only perform about 21 million of these a year. That's about 7% of the overall dental population being imaged. So if about 300 million Americans get an intraoral exam a year, only 7% of them will ever get a panoramic exam. The doses here now, you can see for an adult about 25 microsieverts and a pediatrics about 14.3 microsieverts. So about 2.5 to 1.5. And then the CBCT is even less used. We only do about 5.5 million of these a year. So only about 1.7 or 2% of the entire dental population gets one of these. And here the doses are much higher to the population, 177 or 180 microsieverts, which is approximately 18 days of natural background radiation. And here you can see the pediatric population gets basically the same. So there's not been a lot of optimization in the usage of CBCT because it's just not really used that often. So doses are pretty much the same for kids as they are for adults. Part of that is because as we all know, bones and teeth, they basically are as hard, by the time we get, our bones, for example, by the time we're about 8 or 9 years old, are as ossified at 8 or 9 as they are when we're adults. And that's so when it comes down to imaging teeth and the bones in the jaw, there's really no distinction between a kid and an adult. That and our faces, they grow logarithmically. And so usually by the time we hit 8, 9, 10 years old, our faces are getting large, are approaching about the same size as our face that we would have, the rest of our adult life. And so that's why there's very little, I think, modification when it comes to this. That said, there's still a lot of room that we can modify. Obviously, we can modify it when we do panoramics. They reduce them by about half. So I would argue there's still room to modify in CBCT. But once again, we just don't really do that many of them. So I think no one's really tried. So, when you look at the Thai DRLs, so tying this all to, you guys have done a lot of great work back in 2017 collecting data for intraoral. So looking at, of course, the various different teeth or intraoral examinations. You've got your DRLs shown here at the 75th percentile, and it shows with the Erikerma. So that's great. And you both did it for digital and for screen film. And that's wonderful that you distinguish between the two because, of course, they are going to be subtly different. Film is always higher. As you can see here, it's about 2 times as high as digital. Now, of course, you don't have any CBCT or panoramic, and that's fine because we don't have that here in the U.S. My guess, just population-wise, we do more. But even then, we don't do it because it's such a small population that get the panoramic and CBCT. That said, it's also very helpful to start tracking those numbers. So when we started tracking these numbers back in 2016, that's when we started to realize the discrepancy. Such, for example, the CBCT there is no dose reduction or any dose optimization for kids, and these doses are obviously much higher than the intraoral. And so starting to collect the data is very helpful. You might not actually publish DRLs anytime soon, but as you start to get you should start sending out surveys. And as you survey for the intraoral, it would be helpful to at least start asking, how many panoramics a year are performed and maybe what's the average output. And then as time goes on, you can start maybe actually including that as a specific question, getting specific survey data back for maybe an average size adult panoramic and an average size adult 3D tooth or something like that for the CBCT. And I would imagine the vast majority of the dental clinics that send that data back to you guys for processing would probably mark not applicable, but you will start to see that and start collecting that, especially maybe in the larger regional areas, throughout Thailand. And you can start to collect that data towards setting up a DRL. So now shifting gears real quick, let's talk about CBCT in interventional fluoro. We kind of already did talk a little bit about this when we talked fluoro about a month ago. We actually talked about it when we compared interventional fluoro on a traditional CT scanner versus CBCT fluoro in a traditional CT scanner versus a C-arm system. So I'm not going to add that much more information, but I wanted just to talk a little bit about some new actually very new technology that we've just been testing and working with Philips to develop. So let me get to that. So obviously, what are the uses? You could largely group these two. The use of CBCT in IR in angiographic and non-angiographic procedures. My personal experience is on the non-angiographic, where we do a lot of biopsies in our pediatric hospital. And so I would say I've worked the closest with our IR docs trying to set up good dose reduction and imaging practices for our cone beam CT acquisitions. What are the primary advantages of using CBCT over traditional CT scanners? So C-arm versus traditional CT. The C-arm system has a better, higher spatial resolution. And it's because of the type of detector. It's a large, flat panel, really small detector elements, teeny, much smaller than the actual traditional CT scanner. And so you get really good spatial resolution with the C-arm CBCT systems. The primary limitation of these, however, is that they are slow. It takes about 8 seconds to do 3/4 of a spin around a body. So if you're doing, say, you're doing a CBCT for lung localization for needle advancement, it'll take 8 seconds. If you do it for the body, it'll take 8 seconds. The only difference is typically when you do a head, because it's smaller, and because the system is at the end of the table, at the head, you'll do what's called a propeller, where it'll spin around quite literally like a propeller, like an airplane propeller, and that will go around real quick, 4 seconds. But when it's in the traditional situation where it's going to spin around the body in a C-arm motion, it can only go about 8 seconds. So it's slow. Therefore, if there's breathing motion, cardiac motion, or even just physical motion, even though most of the time these patients are anesthetized and they're out, but if there's ever any kind of motion, that's going to cause blur. There are lots of artifacts in these systems. We've already kind of talked about them with the fluoro unit, so I won't get into them, but we're getting better. We're getting a lot better at fixing the look, the quality of the image, but there are still artifacts that are hard to clear up. Now, what I mean by smaller field of view is the detector itself is larger than an actual traditional CT scanner. So per spin, you get a pretty large field of view. The difference is a traditional CT scanner can raster or scan through the body. So if you want an image of the entire chest, or at least the whole lung field, you can do that in less than a second on a normal CT scanner. But in a CBCT, because of its limited field of view, you can spin once, but if it's a large chest, you're going to have to physically then move the system and spin again. So you're talking a matter of minutes to acquire the entire setup of the lung. So typically what will happen is if you're doing a biopsy, as an example, you basically know where it is because they've already done some other imaging and MR, CT, et cetera. And then you kind of know where it is. So they will position the system centered on that and spin there, and it will never move. It just basically stays in that same location and keeps imaging the body. The overall contrast to noise ratio for these C-arm CBCT systems is about 1.5 to 2 times lower than traditional CT. So if you're really used to looking at that really good, beautiful gray, white, black, grayscale values and good contrast, low noise contrast in traditional CT, these images will not look that good because the contrast is lower and we typically don't really use that much contrast. You can do contrast injections, you can, and that is done, but it's not as typical as is a traditional CT where we almost always use contrast, IV contrast. All right, so historically, how were these systems used? Historically, if you were going to do some kind of preoperative planning or biopsy, you would actually use a traditional CT scanner. You do the normal workup on the CT scanner. You would then take the patient up to the surgery suite or the interventional suite, and then at some level you would fuse the 3D data from the CT scanner with the 2D fluoroscopic data that you got in the room. And the technology is pretty good about doing that. And so for a lot of people, that's what they do. They don't actually do a lot of CBCT in the room. That said, some will still do the traditional CT workup. They'll get the patient in the room, do a single CBCT, and then they'll fuse the two data sets again, or they'll even fuse like an MR set. And so they're really only using the CBCT scan as a way to fuse other data sets. So that's historically how we've kind of done it. But in the last couple of years, I would argue that the technology has become so much better and the reconstruction algorithms have improved such that we, at least at our institution, I can speak for us, we mostly do all of our work in the interventional suite. We do not take our patients down to the regular CT scanner, do all their imaging, take them up to the suite, do all their procedure, and then take them back to the CT scan, system to do their follow-up. What happens now is the patient comes in, they're prepped for surgery or the procedure, they're anesthetized, they're there, and whenever there needs to be volumetric imaging, we do the spin. We do the CBCT spin. And then they'll do the localization, they do whatever they need, and then they'll flip back over to just traditional fluoro mode, and then they'll perform whatever procedure they need to. And so oftentimes we will actually bounce back and forth between doing these spins. So this is a Philips unit. We have Philips at our center. So they call it Expert CT. And so that's why you see Expert CT roll, 8 seconds. Excuse me. So typically you'll see that Expert CT roll 1, 2, maybe even 3 or 4 times in an actual procedure. And then you'll find these 2 frames per second right here. You'll see these fluoro acquisitions kind of intermingled between it. And so that's what's beautiful about using CBCT in an interventional suite is you can do volumetric and then flip back to 2-dimensional imaging just really quick. It's just a button push. And we do that a lot for acquire the imaging, doing all of our planning of our localization planning for needle trajectories, so we can do biopsies as an example. So comparing the doses to the CBCT scans on a C-arm interventional system compared to what we would actually acquire on a traditional CT. Traditional CT is shown here in orange. And the, sorry, I got a dust bunny or something in my throat all of a sudden. It's kind of itching my throat. And the C-arm CBCT is shown in blue. And so you can see that for the most part, they're pretty much the same. The biggest difference, and that's what these solid blue values are, is we will, as you can see here, we'll do sometimes 4, 5, or 6 rolls. And so when you start adding them all up, of course, they're higher dose, and that's why they're up here. But when you just compare them 1-to-1, one CBCT to one CT, you can see that they basically overlap down here. So the one thing I wanted to talk about is kind of the new technology that's come out. Actually just barely did this. We were working with, like I mentioned, we have Philips technology. So I'm not trying to advocate that they're better than anyone else. I'm just saying that I've worked with Philips. And we were working with them, and they have typically only had one protocol for CBCT, for one spin. And they called it their abdomen protocol for whatever reason. And so if you did a CBCT of the chest or the abdomen or anywhere in the body, there was that one protocol. They had, I should say they have one for the head, but we're not talking about that today. And those doses were just a lot higher. And they only have it for adults, period. And so we challenged them and asked them if they could come up with a lower dose protocol meant specifically for doing imaging of the chest or lungs when we do all of our lung biopsies. And they came up with 4 different flavors or 4 different options where you get a new chest or lung CBCT at its normal traditional dose. And then they also provided options that reduced 25, 50, and 75% dose reduction. So here you can see the results of the new sequences. And the one on the left right here, this 100% abdomen, that's what we've been using for years and years and years. That's the one. My guess is if you have a Philips system and you do it CBCT, that this protocol is the one right here. Is what you use. And we took our anthropomorphic phantoms, our adult phantom and our 5-year-old phantom, and we put a bunch of our detectors in them, and we measured all their organ doses, and we calculated the effective dose for those populations. And once again, you basically see that the doses are kind of the same. And that's just because there's never really been any consideration to modify the radiation output based on if it's a small kid or a big patient. And so here, fast forward to the next, or going over to the right, this right here is their new protocol meant for use in the chest when we're doing lung localizations. And here you can see for the adults, you can see there was about a 30% dose reduction. And what's beautiful here now is they were able to make the modification so that for a smaller patient, the system is more aggressive at dose reduction. And here you can see the patient, a 5-year-old gets a 60% dose reduction. And then if you start to look at their 25, 50, and 75% reduction protocols, and they actually don't go that much lower. So even though they call them 25, 50, and 75% reduction, we actually don't see a 75% reduction from this bar plot to this bar plot. We do see some more. It actually reduces it by about 20%. So for what it's worth, we only use this protocol now. We use the one on the left for our typical abdomen or body imaging, and the one on to next to it, right here to its right, we use that for all of our chest lobes. The only reason I bring this up is that we do a lot of we're starting to do a lot more CBCT. I believe the whole field, interventional fluoro, is moving this way, and I believe that that's it. We've come to that tipping point where we need to now start to ask the vendors to produce low dose, better optimized protocols for routine use of CBCT. 20 years ago, we were imaging kids and adults roughly the same, in traditional CT. There were really no considerations for pediatric imaging. And then obviously we realized that we were overdosing kids by 4 or 5 times as much. So fast forward now, our kid doses are so much lower, and so are our adult doses. We're at that same point now for CBCT in the C-arm or the interventional fluoroscopy system. So real quick, obviously we've talked dose. I've been talking about dose reductions. The images on the bottom come from the old protocol that we've always been using, the quote unquote abdomen, and the ones on the top are the new chest or the lung protocol. And the columns, so A, D, B, E, C, F, those are kind of paired in age, as best as I could. You know, this guy's a 7-year-old down here, and this is a 13-year-old, so not exact. But this guy over here is a let's see here. Where are you? C is a 5-year-old, and F is a 5-year-old. So those two are 5-year-olds. But the point here is, just at first blush, kind of looking back, leaning back, I would argue the image quality is the same. We measured noise, we measured a couple of other metrics, and it is true. Image quality is basically the same. Noise is about the same. Contrast to noise resolution was about the same. The ability to visualize the pathology of interest, in this case, the tumor, it was all the same. So there is a lot of room for lower dose CBCT is, I guess, the overall conclusion that I would get to. All right. So that's really what I had for this.
Thank you so much, Sam, for clarifications. So this means actually I saw, and I think we work with the Convim CT for a while, because in the neuro IR, when we do the angiogram, and couple times we have the spin images for the aneurysm after, before or after clipping. So that is a Convim CT image.
Yeah.
Wow.
Yep. So okay. We've definitely done a few in the, I would say neuro probably was a little bit quicker to adopt CBCT. And that's obviously because it's easier to do a spin of the head. It's because you could just position it at the end of the table, and the system could quite literally just go right around it real quick. And it creates a very nicer looking image because of the way they can acquire it. But now that it's getting more popular down in the chest and, of course, the abdomen, the pelvis, there's a lot of room for continued growth and development.
Yeah. So which means, so if it comes to the dose, the dose registration or DRL things, how so do we do the separate For
Yes.
the IR, okay, like one part is like for the CT part and another part for the IR, like for the fluoroscopy, right?
Yeah, and you guys have started already collecting what we've talked about, and we'll actually I'll share with you again your DRLs for interventional.
Yes.
And Kath really doesn't do it, but interventional IR. So the answer is you could start doing the surveys and start asking those questions. You know, what is your typical CBCT of, say, neuro and body? And that's good information to start collecting. That said, you once again, it's very specific. You know, biopsies, we use it a lot. Other, you know, when you come back to the different usages, you probably won't use, you know, stent graft placement, maybe one, thrombolysis, biolysis. Sorry, I can't speak. You might not even use a CBCT. So once again, when it comes to interventional, the type of procedure is very specific to it's really hard to establish DRLs. And so it's even harder to then add the CBC to that. But if you're doing a lot of CBCT routinely, then you need to consider the fact that the overall air kerma value for the procedure is going to be skewed higher if there's a lot of CBCT. And so it's probably good. When the hospital sends the overall cumulative air kerma for, say, a biopsy, you're going to write that down. That becomes your DRL, and that's what it is. But you may also ask a follow-up question, you know, do you do CBCT, and what would be the typical CBCT dose for those biopsies? And it might be another, you know, whatever percentage of that. And then you would list that as separate. So you don't necessarily need to subtract the two. You don't necessarily need to take the CBCT dose out of the interventional procedure because it's part of the procedure. You want to kind of collect that. But you could list it separately so that people know that these are kind of the rough dose levels that you should still be aiming for when you do a biopsy if you include a CBCT.
I see อาจารย์มีคอมเมนต์มีคำถามเพิ่มเติมไหมคะ
I would like to ask that the radiation therapy also use cone beam CT, and is it the same as a fluoroscopy cone beam or not?
It is the same concept. The biggest difference is here. Let me just pull this up real quick. There we go. Can you see my Google page?
Yes.
Okay. So in interventional, I mean, all the different vendors, Varian, everyone, they all have different approaches. And they're going to have a flat panel on one side and a detector on the other, an X-ray tube on the other side. And this whole system is going to spin around, and they're going to still be able to do a CBCT or a cone beam. So everything we talked about is the same. The biggest difference is now your geometries are larger. So these machines are, anyone that's ever been in these suites, they know these machines are big. So the distance from the X-ray tube to the detector is larger, and the system goes really slow because it's a really big machine. And so the doses tend to be much higher. And because of the trajectory and the limitations of where they can actually image in the body, if you have a large body on the table, I don't even know if we have a picture of it. Well, that's not exactly a large person. But if you have a large body on the table, you actually have to shift the patient. You can't do, in a normal CT scanner, the field of view is large enough, it's 50 centimeters. We can just one full swing, full spin, and you get a full 50 centimeter field of view. In these, the field of view is smaller. And so if you're doing, say, the liver imaging, you'll actually center the image or the center of the rotation over the liver. So the patient is shifted and you spin around. So you actually don't get the whole abdomen. You only get, of course, the liver. But because it's offset, you also get a lot of artifacting. I worked with a gentleman way back in the day, about 15 years ago, when they started developing CBCT for RO, for radiation oncology. And back in the day, it was hard to even read those images. But nowadays, the images are standard. They'll almost always, they will obviously take the CT scan, they'll do all the simulations beforehand. They'll come in, they'll get the patient placed in position, and then they'll do a cone beam CT to make sure everything's aligned properly. And they'll even bring in the true traditional CT, and they'll fuse the two so that they can actually do maybe Hounsfield U calculations to make sure the planning, the dose plan is going to be delivered properly. And then, of course, as they apply it, or as they actually go through and start treating the patient, they can at times set it up so that they can do live imaging. So you have the X-ray system going at the same time as the MV system, and that allows them to track, motion, if the patient's breathing, if the heart's pumping. And so they're actually able to keep the volume, the target volume, better centered. And so it's really amazing what they can do now in interventional, not interventional, in radiation oncology.
Yes.
That said, these doses tend to be a lot higher.
Sam, there is a couple questions. So one from the chat box. So if we want to compare for the dose metric on the cone beam CT to the conventional CT, can we use do we still use like a CTDI volume, or do we use a DAP to compare?
Yeah, I would use volume CTDI. So one thing I probably should have done is added one more column right here. So this would be your traditional CT. So when you're looking at kind of the face down here, just the mouth, we're talking somewhere in the 15 to 25 range. And the way that these systems are measured, or the way we calculate the CT, it's the same way we calculate CTDI. We're still using the same phantom right here that you see on my screen. These little 16 centimeters, the smaller of the two. And you place the same phantom on the machine. Here we go. Perfect. So what you do is you take this little blue piece out where the patient bites. You just pop that off, and you take the CTDI phantom and you place it on it, just like as if there was a head there. And you place your ion chamber in it, and you spin it around. The biggest problem with that is when these machines spin around, let's assume we had an ion CTDI phantom sitting right here. The machine doesn't do a full 360. It will do a part 3/4 of the way. So you can't, if you put your chamber in the dead center, you'll get one measurement. And if you put it over on the left, you get one, and you put it on the right, you get a different. The numbers are different. If you put it in a real traditional CT scanner, because it can go all the way around, the left and right numbers are almost always the same. So when you do the CTDI calculations in these machines, you have to be very careful how you set up the phantom and where you put your ion chamber to make all your measurements. That said, it's the same calculation. When these numbers, this 4 and this 10, I actually physically measured using my phantom, my 100 millimeter or my 10 centimeter ion chamber. I did the rotation, I did all my averages, and I still did the same calculations.
Mm-hmm.
So it's probably the best way. If you're going to compare CBCT, use this CTDI vol. That said, there is no volume CTDI calculations for panoramic images. So the only way to compare those are DAPs. But you're only comparing a panoramic to, for example, an intraoral.
Mm-hmm.
And should we calculate the DLP from the CTDI volume and the length of the receptor?
The answer is no. And that is because for these systems, it's a single rotation. You cannot collimate the field of view. It is one field of view. You can, you know, when you're imaging here, the only thing you can change is the area of focus. So you might be able to come over here and you might be able to center like on the front tooth or the front left, front right, or, you know, the system, because of its limited field of view, you're only going to be able to image maybe part of the face. And if it's a small enough face, then you can get the whole thing. But, you know, right here, you can kind of see this blue, green, blue. You can see how it changes the kind of the area in the front or maybe the sides. That said, this is actually a bad graphic because you can't collimate this way. It's always going to be the same size. It's always going to be the same size. You would never be able to do that. So this is a bad graphic. I don't even know what they're doing with there. So the answer is you'll never have a DLP. No DLPs in this.
I see. So there is another questions from the Facebook Live. So when we do the fluoroscopy in the IR suite with cone beam CT, so and is there any heat issue?
Heat
That
issue?
can happen. Heat. I mean, like because when you do like a fluoroscopy and cone beam CT, maybe like in one patient you do like a multiple spin for the cone beam CT.
Are we talking like skin reaction?
Yeah, it's not like only the skin reaction. It's also like I think it's like the tube heat in the tube. Yeah, for the machine. Broken
so the answer is yeah. No, the machine is fine. Yes, you are acquiring more images, but the fluoro, the dental, the X-ray tube in a C-arm fluoroscopy, these, whoop, sorry. There you go. These X-ray tubes right here are actively cooled, and so you can use them. I mean, you may use them for interventional procedures for 2 or 3 hours. And so if you do one CBCT, it's not that big a deal. If you did 100 CBCTs, maybe, but no one's ever going to do that. But these systems, they're very good at keeping the heat down. So no, you shouldn't have to worry about that.
Okay. So
but then also just to talk kind of a little bit about the skin. So fluoro, of course, the dose is the X-rays are always coming in one angle. And so that's why we have to worry about the dose to the skin. But in CBCT, of course, it spins it around. And so now the dose is being distributed. So we actually don't worry as much about skin burns in CBCT. In that case, we're now worried more about the organ doses internal to the body. So that's a completely different discussion, though.
Oh, that's good. Yeah. Okay. So I think we can อาจารย์มีคำถามอีกเพิ่มไหมคะหรือถ้าไม่มีเลยค่ะน่าจะค่ะ Okay. So I think we can move on to your next talk on the dose index registration, how to start and like how to interpret the data.
Sure. And so the one thing I would say is when we did talk fluoroscopy, which was about a month ago, we talked about doing all the CTDI calculations and whatnot in the IR suite. So that's why I didn't even talk about it today, because technically we reviewed that. So if anyone has any questions, they can go back to those slides.
Sure.
All right. Let me grab the next talk. Okay, so now we're going to talk about today's topic, right? We're actually going to talk about what we're supposed to talk about.
Yeah. Hey, Sam, can I like interrupt you one more question? From the chat box, is the wide beam concept and 10 centimeter chamber able to apply for the cone beam CT? I think.
So the answer is yes. And that is because So specifically going back to these systems, the cone beam CT, well, whoops. If you focus on this middle picture, let's just assume this middle picture is the right one. The actual area, the field of view area, is small enough to fit in a 10 centimeter beam. There are limitations for interventional system. We talked quite a bit about those. So the answer is it's not very accurate when you use a 10 centimeter ion chamber in the interventional system. But like I said, go back to those slides. We talked quite a bit about that, and you'll know. But for the CBCT system, the area of the field of view is usually smaller than 10 centimeters. If it's not, then the answer is these numbers that I gave you in this right here. What you do is if you go into your system and you measure the field of view area, what you can do is I take some radiochromic film. So radiochromic film is something you can just go online and buy. It's really easy. Good heavens, what is the name of the company? Ashland. Ashland is what the company's called. Well, here's a picture. You can kind of see that it's film that you can actually hold in this. It's not regular film that would develop in normal light. It's film that you can only develop when it's irradiated. So you can actually just tape it to the detector side. Where's my system? So you can come over here. You have the detector over here and the X-ray tube. So you would physically tape the film, the radiochromic film, to this side. Take everything out of here. Take the little stand. Take all that out. So it's just a clean shot. Acquire one image, and then what'll happen is you'll see just a vertical line, and that's the field of view. And you'll be able to measure the top to the bottom. You'll know exactly how tall your system's field of view is. And then you'll know if your 10 centimeter probe, your ion chamber, will cover that, or if the field of view is larger, because maybe your system is larger. And if that's the case, there's nothing else you can do. You still use the chamber, you still make the calculation, but you just have to know then that when you compare these numbers, these two numbers will not be as accurate to compare, because a traditional CT scanner, typically when we're acquiring, when we're calculating CTDI for like a maxillofacial or a more coned in protocol, those are going to have maybe 4 centimeters, maybe 8 centimeter field of views, in which case they're always going to be smaller than the 10 centimeter scanner, unless you're using one of the newer systems, which is 160 slices, or 16 centimeters. So the answer is we could probably talk about that for another 10 or 15 minutes. If it's really the only tool you have, that 10 centimeter probes, you use it and you make your calculation. I don't normally go and I compare my dental CBCT system to my traditional CT. I typically make these measurements, the ones you see right here. I make those measurements every year, and I make sure they're the same every year. So that's how I know my dental unit is performing okay. And then I make, of course, all these measurements on my regular CT, and I make sure those are staying the same. And just know that the CBCT unit used in dentistry is going to be typically lower than that of regular CT. All right.
That's good. Thank you.
Yep. All right. So let's talk a little bit about, it's not necessarily a review, because we really haven't talked about setting up an index registry, but we've talked quite a bit about this whole process for these last 3 months. So it's going to feel like we're reviewing things. So I just want to do a quick acknowledgement. A good friend of mine, Sarah McKinney, Dr. McKinney from Stanford University in California, she did a survey. And what she did is she looked at the various different softwares, the dose collecting softwares we have that you can buy. And she basically came up with a pros and a cons list. So there are some slides I have today in my talk that she let me borrow. So I just want to acknowledge that those are her talk slides. Some of these slides are hers. All right. So historically, how have we collected data when we have tried to estimate risk? Well, most of the time, most of the publications that we have read about over the last 10 to 15 years have all been retrospective studies. And they have never collected data from databases because, for example, when we did this out of Australia, where they looked at, they looked at all of these different head scans in kids, and they said that there is a chance for increased cancer risk from CT. They did, the same study over here in the U.S. and they did one in the U.K. Well, all they could do is go back to the 1990s and the very early 2000s, and they just looked at the type of MA, KV, and exposure times that were typically used. They had no dose information. They had none. Well, they had the CTDI values. They had dose output, but they didn't have it for little Johnny. They didn't have it for Tina. They didn't have it for all of these people. All they had was just a general idea of how much they used to use. And then they just had to make a lot of They had to make a lot of estimates and calculations, and they had to infer from that data what the risk would be to us today. And it should be pointed out that really PACS systems didn't really come into usage until about the mid-90s. Computers just really, for the most part, the internet really didn't come into play until the mid-90s. And so when it comes to doing data analysis in the past, it was very difficult. Nowadays, pretty much all of the systems that we use in radiology are moving towards collecting data using a software-based system. This software-based system is going to allow us to move past this idea of using paper-based surveys. Now, if that's all you've got and you don't have these dose databases that I'm going to talk about in a moment, then the use of paper-based surveys is the only thing you have to do that. The only problem is there's a lot of hand processing. So you need to hire people. You need a lot of people to do the data calculations. You can almost never collect enough data across all of your hospitals to get a really large population sample. So it's going to be a small sample of select hospitals. And you usually, when you do these paper-based surveys, you're only asking the hospital to maybe look at their results, to look at their data and pick maybe the top 5 or 10 most common protocols. And then they'll go look at maybe 50, maybe 100 patients, fill out a survey, get their averages and send it in. They can't physically by hand do a lot. A human's not going to go look at 1,000 or 2,000 physically and do the calculations themselves. It's just harder to do that. So the idea of using software is that we're moving beyond these limitations of looking back in time at old data, and we're removing the limitation of doing everything by hand. And that is why these softwares are really going to revolutionize the way we do DRLs going forward. So there are a lot of options out there. So what do you want to buy? What should you look for? So let's talk about that. So this is a slide from my one friend. So a couple of years ago, she looked at 16 companies. As of 2021, there's even more companies. So even this data is out of date. But she looked at the most popular ones. For example, Radiometrics is the oldest. It's been out there for a long time. GE from DoseWatch has also been out there for a while. All of the major vendors have them, like Siemens, Philips, GE, of course, Bayer, of course, Radiometrics. But these are ones you actually have to pay money for. And oftentimes you have to pay a lot of money for them. And then there's the open source ones. So these are the ones that tomorrow, or even today, if you really wanted to, you could go and you could download OpenREM or Open Dose Monitoring or Radiance. You can actually just go download them right now and you could start doing dose collection. So there's a lot of benefit for some of these. The question is, what do these softwares provide? What modalities do they accept dose reports from? And then how do they process them? So we're going to have to, let's just walk through this process. Let's go through this idea as if you're in the mindset of, if you're trying to purchase a software, you want to set that up in your hospital. What are the steps that you need to go through? What are the questions you need to ask? So the very first question is, when you look at all of the modalities out there, do all of these softwares collect radiation dose from every modality? Now, obviously, MRI and ultrasound do not have ionizing radiation, but some of the vendors, 20% of them will actually collect MRI data if you want to do calculations for usage and all that stuff. But for our purposes, let's just forget the MRI and ultrasound. So the real question is, can all of these softwares that she looked at, and then even all of the new ones since then from 2021, can all of them collect CT data? The answer is yes. And that's because pretty much every one of these softwares were built originally for CT dose data collection. But the problem is not all of them can do X-ray and fluoro and nuclear medicine, etc. And so when you start to look at all of the different softwares, you have to ask yourself, do you want to collect all the data? If you want to find one software solution out there that will collect all this data, you're going to be actually kind of limited, and you have to be careful which ones you pick. So ask which modalities those softwares will collect. Now, the other option is, what else do you need? It's one thing to have software. It's another thing to actually have the machine computing power to run the software. 43% from that list requires you to physically install a server at your hospital. So you need a data center or some IT support to physically locate a server somewhere in the hospital so you could hook up your software to it. Others will allow you to simply take that software and place it all on a server system already established in your hospital. And this is usually the best way to go if you're going to do it, in the sense that most hospitals already have servers. They can simply allocate a little bit of space, such as this shown here in yellow, or a little bit of space over here in blue, to manage your software, your dose data. And then you, as in radiology, do not have to constantly buy new software racks, and you don't have to constantly have an IT support someone to make sure that it's working. That's just handled by the hospital. And then 20% of that list, actually the vendor, the people selling you the software, they will actually have the hardware at their center, at their location, and all of the information goes up to the cloud. So you take your data from CT, X-ray, nuclear medicine, PET, you collect that data, you send it off to the cloud. That cloud data is then processed, and you have access to it on your computer. So the nice part about that is you never have to worry about buying a server or allocating servers or paying someone for IT support. You just have to pay a little bit of extra money for someone to collect your data for you and keep that data safe. So what are some other questions you need to consider? Where does the dose report come from? That means, so the dose data, let's simplify our discussion now. Let's focus on one modality, even though it's applicable for every modality. So you've collected dose data from CT. Where does the dose reporting software collect that data? Does it directly come from the CT scanner? Or some systems, you take the CT data, it goes to PACS, because that's where the radiologists are going to review everything. And then the dose monitoring software will take the data out of PACS. And so the technologists don't have to ever worry. It's just a matter of ending the exam. That stuff goes to PACS, and then the PACS will reroute it to go up to your dose reporting software. All right. When the software receives that data, how does it process it? Does it need to come in a structured dose report, an RDSR? Or can it receive DICOM images? Some of the dose report structures are still just images. So, at the very end of your CT exam, at the very end, they'll show a dose report. Every vendor has something different, but it'll list the CTDI vol, the DLP, the phantom size, all that. That thing that you're looking at is actually a picture. It's an image. And some systems, that's all they have. Other systems have structured dose reports that you'll never see. And so you have to ask this, you have to know which one the system receives, or can it receive both of them? And then after it receives it, does it collect it forever? Does it keep it in its server? Or does it scrape the data off, store it in its software, and then delete the structured dose report? Which is fine, but I've found that if they're not deleting them, the process gets bogged down, and eventually your server starts going slower and slower and slower as you put more and more data into it. All right, what do these estimates provide? So when you actually calculate doses, what ones do they provide? We've talked about in every modality, there are various different dose metrics that you have to be able to understand. Error Kerma, DLP, CTI-vol, DAP, CAP, all of those things. You have to be able to find out if the system will be able to provide calculations for all of those dose metrics. Does it account for size? We'll talk a little bit about that in a moment. How does the system handle combo scans? For me, this is a huge thing in CT. So a lot of times our kids will come in, not a lot, but occasionally our kid will come in. There's suspect the emergency room. It would say they were in a car accident. They suspect that there was some head trauma. So they go in to do just a routine CT of the head, and they're looking for bleeding. They're looking to make sure there's no trauma, nothing like that. And then they see something. So then they will then add a CTA to it, and they'll actually do an angiographic study so they really can understand how bad the bleed is. In that case, they've actually done 2 studies on the same patient. Some softwares will take both of those numbers and add them together. So it will show up in the software. Little Johnny will actually have, it'll be listed as a brain CT because that's what he or she originally showed up for, but it'll be double the dose. And so usually that's when you get a big flag and the system will say, whoa, this dose was way too high. And then an email will come to you and you'll have to try to figure it out. 90-something% of the alerts I get as a medical physicist to look at why the dose was too high was because of that problem right there. It's a combo case. And so the system just doesn't know how to differentiate the two. All right. And then, for an added bonus, can it do fetal dose calculations? So, this is all a little out of order. We talked about how every modality has its dose metric. Your software needs to be able to process every one of those. A lot of the systems will collect that data and calculate effective dose as a way to compare CT to fluoro to X-ray to nukes, which is fine. That is great, but you can't use effective dose for DRLs. So that's okay if it collects the volume CTDI, because that's what you want for DRLs. And error Kermas and your CAPs and DAPs and all of that, that's what you use for DRLs. The effective dose that it collects and calculates is actually a very good thing, and we'll talk about that in the next talk. But you just still need to be able to differentiate and make sure it can do all of that. You don't want it to collect all that, calculate effective dose, and throw away the rest of the data. Some of the more sophisticated softwares will allow you to go beyond CTDI-vol, beyond effective dose, and actually start to estimate what the true patient dose is. And the only way to do that is if you use Monte Carlo. And so the system has to be able to calculate the dose to the organ if you want to know what the patient dose is. And so there's a couple of different ways that you can do this. The system can actually, some of the systems will actually take an image. Usually it will be the scout or the planning radiographic image. And so let's say it was a chest, abdomen, pelvis. So you got the quote unquote scout view of the chest, abdomen, pelvis. And what it'll do then is it'll measure how thick it is, and it will then pick a phantom of similar size, and it will then have all of these organs already established, the volumes, the sizes, the lengths, all that. And then it will use the CTDI-vol and the MAS and the KV. It'll look all of that information that came across from the structured dose report, and it'll use that to calculate the actual organ doses based on Monte Carlo lookup tables. So that's great. But the difference between this image and this image is this is an actual patient image that has all of the critical structures truly segmented. This right here can provide patient dose. Using this, that's obviously not a patient. That's not the patient that got scanned. Let's put it that way. It's pretty darn close. And so it gets us to a little better than using effective dose. It lets us say that a patient population of said size and dimensions will have organ doses such as those calculated. There are sophisticated phantoms, as you can see here on the right, where they actually look geometrically like true patients. I actually know the gentleman that created these NCATs at Duke. He was making them while I was at school at Duke many years ago. And he had a poor, he employed a patient. He paid some guy. He would take hundreds and hundreds of patient CTs, and he would manually segment all of their organs, every one of them. And they just did that over hundreds of thousands of images to the point where they created a library of images of phantoms of all different sizes. So they had all different organ sizes, organ positions, and everything. I mean, I'm sure that guy went cross-eyed doing that many segmentations. But the beautiful thing is we have these more realistic phantoms compared to the ones we've been using since I think this ORNL came out in the 50s, maybe the 60s, where these are great mathematically because they're perfect geometries. Spheroids, squares, rectangulars, cubes, all that stuff. You can do math on those real easy. But you and I do not look like this. The beautiful thing about these NCAT and other type phantoms that they've been developing is you can create different sizes, obviously different genders, and then different patient thicknesses or attenuation levels. So like I said, you can take that scout image that you send over to your dose calculating software. It will look at it and it'll say, oh, that looks like this patient right here. Or it's a 5-year-old, but the 5-year-old's actually a little thicker. And so we'll pick a thicker 5-year-old. And so it's able to do that so you get really accurate organ dose calculations. Now, that all said, organ dose calculations are not going to be helpful for DRLs. They're great for if you're trying to optimize your protocols. They're great for if someone got scanned and it turns out she was pregnant. Now you need to calculate how much the dose was to the fetus. There are all these other reasons why I look at the organ dose calculations for some patients. And to get to a better place where we can actually estimate true risk. So will CT cause cancer in the future? The only way we'll ever be able to answer that question is when we get true patient-specific dosimetry, where we're actually segmenting all the patient organs, calculating those actual organ doses, and collecting them in a database. And so we're getting there. We're actually starting to get there now. So in the future, when we start going back and we look back 10 years and calculate those doses, and then we look at the cancer incidence rate among them, then we can actually start to maybe estimate, is there a true correlation? Now that's a completely different debate. We can talk about that another time. All right, so moving on. These software systems, I mentioned they calculate effective dose. Do they calculate effective dose using these phantoms because they have now all the organ doses? Or is it simple where they just take, for example, a CT, the dose length product and times it by a correction factor? If it does the simple version, you need to make sure they use the more accurate correction factors. There's some old correction factors that are still being used out there. It surprises me. There are some publications out there that people still use the old correction values that were developed in the 1990s. And there was a paper that came out in 2010. So, I mean, even this paper is starting to get old. But this paper is the paper you use. Google Deek et al. Radiology 2010. That'll give you the more accurate way to calculate effective dose using DLP and a correction value for CT. All right. So once it's all said and done with, you've kind of picked your software. You know that it's collecting the dose structured reports from all the different modalities. You've set it up. It's either going to a server, going to a cloud, whatever. The data is flowing now. The question will be that you need to ask is how will that data come back to you? Will it simply be in a tabulated form like this? Or will it come back with all these beautiful little graphics and scatter plots? And here you can see the type of phantom it uses to do its organ dose calculations listed here. These two softwares we actually have here at our hospital. One does simple tabulated calculations. Another one gives you all kind of rich data. It really depends on you and how you process it. I personally love the tabulated because I actually download that and I write my own codes and my own software. My software processes the data how I want it. This software is great if you don't want to deal with that, but you just have to know that it's limited. If you want to look at this data a very specific way, if the software can't do that, that's okay. You just can't. You can't process it that way. But if the data is provided in a way that is helpful for you, then you're good to go. So those softwares do provide a lot of graphs and reports, but they're structured the way they think. They, as in the vendor, the software developer. All right. So what you want to do is, if you're going to purchase this software, or you're considering getting it, if you ask for a demo, ask them very specific questions. So when we're actually shopping to buy a new software and to change platforms, so the question I ask them is, what is the average head CT dose for a 3 to 5 year old? And then what I do is I time them and I ask them to produce that, answer that question. And they have to then look at their data, their software with all of our data in it. And then they have to click and click and click and click, and they create a plot and they answer that question. Did it take 20, 30 seconds? Did it take a minute? Did it take 20 clicks? Or were they able to, within 2 or 3 clicks and within 10 seconds, answer the question real easy? So it just depends on how difficult the software is to use. And just come up with a variety of scenarios. Come up with 5 or 10 scenarios, easy ones and more difficult ones, and literally time them and see how it goes. Count how many clicks it takes them to get to that answer. And you'll find that some software options out there are much better, more efficient than others. All right. Once the software is then, once it's reporting, the question is, how does it deal with those notifications? So like I mentioned, there are the occasional scans where the patient comes in for a head CT. It's listed as protocol as head CT, and they'll add a CTA on. And then all of a sudden, boom, I get a dose notification. How does the system report outliers? Does it generate a report? Does it send you an email? How does it deal with all this? Some of these systems, or 100% of these systems, will provide either emails, PDFs, some kind of dose alert that you can download and process. Others, only 90% of them, will actually have on their system basically a way to alert you in the software. And then it'll tell you which exam it was, which CT scan it was, which technologist acquired the image. And then only a small section of less than 50% of these softwares out there will provide reports for the actual referring physicians. In other words, I don't even know why you'd want to do that, to be frank, but it provides a way to put that report, that dose notification, out into like the EHR, the hospital, the patient charts and whatnot. I don't know why you'd necessarily want to do that per se, but some of them are getting more what's the word I'm looking for here? They're becoming more integrated into the actual software ecosystem in the hospital. This is, I guess, the best way to explain it. Right now, most dose reporting softwares are just separate. You send data to it, It processes things. You push a bunch of buttons, it gives you reports. We're trying to get to the point where the data goes in, the system processes it, finds problems, alerts you, sends information to PACS so that when the radiologist is reading it, they'll get maybe an alert or they'll get a notification of the actual dose level. And some of them are starting to archive this dose data back into the patient report charts or the patient records, so that with time, let's say a patient is a frequent flyer, comes in multiple times, the dose reporting software will collect that, but the hospital software would never know that this patient has received so many milligrams of radiation. And this system is a way to kind of start accumulating that, simply saying, here's kind of the total dose burden. Now that's controversial. Do we accumulate dose? Do we calculate it? Is this dose, the scan that we got 10 years ago, the same dose risk as the scan that we get today? And I would say no. But from what it's worth, a lot of these softwares are starting to do that. They're starting to collect, integrate, and report that data out. So you have to be careful how your hospital will use that data. All right, so there are some softwares that are now actually allowing you to track image voting. And this is actually really a neat option. So what that means is the study goes to PACS, the PACS pulls it up, radiologist reads it, and when they go to close it, a box will pop up. And it'll say, was the image quality good or bad, or on a scale of 1 to 5, was the image quality. It's a simple way for the radiologist to say, yeah, the image quality was okay, or no, I really didn't like that. I didn't feel like that scan itself was a good scan. So they would just simply push a button and it'll go away. But this software collects that. And so now you got a dose report and an image quality report, and you're able to kind of process the two. One of the software options allows you to physically change and map protocol optimization. So that's kind of a fun feature if you're, especially in a large hospital and you're trying to optimize protocols across a lot of different scanners. There are some softwares that will take the dose report, as I mentioned, and it will physically place that into the PACS or into the radiologist's dictated report. So the radiologist doesn't have to dictate that so-and-so got so much air kerma or volume CTDI. The system will immediately just place it into their report. All right, so these softwares are the strongest when it comes to helping you guys meet legal requirements. That's probably more of on us here in the US. This is becoming a legal requirement that we dictate and we report patient doses. But excuse me, one of the nice things about this is it allows you to do a lot of quality control analysis on your own. You can query individual cases, you can query it by protocols and find protocols that are too high or too low. This is all stuff that you can do internally. And then eventually you take this data and you push it off for DRL calculations. But then the the nation, Thailand, eventually comes out with their DRLs. And now you're able to compare those DRLs to all the data you have in your dose reporting system. Some of the weaknesses of this system is that, of course, it does not track risk, true defined risk, because it's not actual patient data. It's a close estimate. So we don't actually know what stochastic risk is. I mentioned some of them are starting to accumulate the total patient dose. And I believe that's actually a bad thing, because the scan they got yesterday and the scan they'll get tomorrow, the risk assessment for both of those are two different things. And just because someone's had 10 CT scans in their past doesn't necessarily mean they're at more risk tomorrow. There's a lot of variations. There's a lot of variables that you need to take into account when you calculate overall risk. How they calculate an effective dose is somewhat of a black box. We talked about the two different ways. Yep. Okay. So probably the other thing that's really important for you to know is not all of these softwares can actually interface with a national-based dose registry. So if the end goal for you is to get this software at multiple different hospitals in your hospital, in your nation or in a region, you need to make sure that these softwares have the ability to export data and collect that data and aggregate it. And so only 67% of them are actually capable of interfacing with an external server and providing that data in a format that they can then process it. And so we just talked about that. And then finally, once you've selected this software, it's bringing all that data out of the modality into a central repository. That repository is then sending it off to a national center. The national center eventually is going to start hopefully providing data back. So this is kind of the step that we're at in the US. We've collected data for many, many, many years. We set up DRLs, and now we're to the point where the flow of data is constant. We constantly get data from the hospitals to the national processing centers, and then those national processing centers every quarter will send a report to all the hospitals. And those hospitals will get something like this. This is quite literally just a snapshot of one of our figures. It will show you the statistics of the 10 most common exams. In this case, these are CT exams listed here. It'll show, of course, the mins, the maxes, the first quartile, the median, the third quartile. And then this red line is actually our hospital's data. So it shows our average compared to the national average, which is shown in the box plot. And so in most cases, our hospital is pretty low. You may argue in some cases it might be too low. But the point here is it gives us a way to compare the doses, and it allows us to compare them by region. So I can compare my hospital to Tanya's hospital because she and I are in the same region. And of course she works at a children's hospital. We can compare it as a function of patient size, doing SSDE. You can do it as a function of patient age, although I don't necessarily agree with that because size is the most important metric, etc. You can break it down and you can do a lot of comparisons. I'm just going to skip over that for now, since we're kind of running a little low on time. So let's talk about dose registries. All right. So yeah. So what are some of the limitations of the current setup? Right now, none of the dose tracking softwares, everything on that list I showed prior, they all can send one way to the National Dose Registry, but none of them receive back from the dose registry. To this date, all we get is a PDF report. I'm hoping that as time goes on, these softwares will eventually return data back so that you can then process it and it would show and compare your data to other people's data. So we'll get there, I think, eventually. But for now, everything is processed using an Excel spreadsheet. So what you need to do is you need to establish an analysis team. Once you've got this whole system flowing, you got data going to and data coming back based on national DRLs, you need to be able to analyze and make sense of this data. So you're going to have someone like a physicist, a CT manager or an X-ray manager, a floor manager. You're going to have a technologist manager over all the different modalities, and you're going to have a variety of radiologists that specialize in the various different exam types that come from different modalities. So you'll have someone that's like a neuro doc, a body doc, an interventional doc, etc. And those are the people that'll help make sense of the data. So in our case, our data is a little low. We're actually at the 25th percentile. So we meet quarterly and we ask ourselves, was the image quality what we have, is it sufficient? Is it maybe too low? What should we do to improve it? So convening that group, this little group right here, this analysis team periodically is a great way to make sure your doses are constantly where they're at and the image quality is where they're at. And we already talked about this in the past where the DRL is that target. Getting below the DRL is a good goal when it's applicable. And then if you're below the target of DRL, what do you do with it? So we'll talk about that in the next talk a little bit more. So what are some very generic steps on setting up the next step, which is the National Dose Registry? So we've been talking all about the software you would need at your local hospital and the steps to go through to figure out which software you'd want and the steps that you would go to get the data from the modality to a point where it can go to a National Dose Registry. But now for those of you that are working on setting up a National Dose Registry, you can go to this website. This website is for the ACR, American College of Radiology. Here in the US, they've been doing this now for, good heavens, probably 15 years, at least over 10 years. They've set up the National Dose Registry here for us in the US. And so all of the steps I'm going to take from them come from this website. So go there, you can read it. They have a lot of great examples. So the first thing they advocate doing is establishing a group of experts. So we've already kind of talked about that. But more specifically, at the hospital level, more specifically, you need a person that will become basically your account manager. So if you work at Hospital A, that person is going to make sure all of the data from Hospital A gets to the National Dose Registry. And if there's ever an issue with the National Dose Registry, they know who to call. And that person A is usually not a radiologist. It's usually someone that has technical expertise, a computer-based knowledge person. It's someone that can work with and help this data transfer. They're usually not a person that's going to make sense of the data. They don't need to know what a CTDI is or an error curve value is. You also need key IT support staff. You need someone that deals with this consistently, that's kind of assigned this task. And they're the ones that will be able to make sure that the data flows. Typically, at least for us here in the US at our hospital, we have an IT support structure. And then in radiology, we have our own specialized IT that runs our PACS system. And so the individuals that help us with our PACS IT are the ones that help us get our data from our hospital up to the NDR. You will need people like me. You'll need a physicist or some kind of trained technologist. You need someone to make sure the data is leaving your hospital in a good format. In other words, you need to make sure all the dose data is accurate. You need to make sure that it's all labeled properly. And then when it comes back, that you're able to use it properly to compare. Ultimately, if you're sending bad data up to the national government, you're going to get bad data back. So you would also need to have a lead radiologist to champion this whole data process. They're not necessarily going to be the ones running it, but they're the ones that are going to be in charge of it to make sure that you got IT support, you got physics, technologist support, you got everyone in the right place, and that the department is able to support that whole process going forward. All right, and we talked about the QC process. The second step is you need to create a way to have accounts. In other words, once you set up the National Dose Registry, you need to be able to uniquely identify every hospital in the system. And there is additionally some hospital systems that have multiple physical hospitals in it. And so you'll need to have a general account for for example, here in the US, we have the Mayo Clinic. That's a very popular nationwide center. The Mayo Clinic is located in one location in the US, but they have hospitals all over the US. And so you would need a general account for the Mayo Clinic, but then Mayo Clinic in one city and state, another Mayo Clinic in a different city and state would have sub accounts. And then you would break them down because even underneath those, some of them may have CT, some may not do CT, etc. And so you need to have a unique way to identify all of these accounts. You need to then determine how the software will get from the hospital to the National Dose Registry. We've talked a little bit about how data flows internally, such as from each of the modalities to PACS, and the PACS would go to the structured dose reporting. and the PACS system could maybe even send it up to the National Dose Registry. Or you might end up where you use the radiation dose monitoring system software that we've been talking about. Maybe all the data flows into it and it goes off to the National Dose Registry. So there are a variety of different ways to approach it. It obviously depends on the software you buy or you download. You just need to make sure that you get it processing so it's all efficient every time. The next thing they talk about is you need to get a good naming convention. So if one hospital names their CT abdomen angio with and without one way, and another hospital names a different way, when all the data goes up to the National Dose Registry, you'll have 100 names for the same type of exam. And that makes a big headache, especially at the National Dose Registry. So you need to establish a generic lexicon. So if someone does a CT abdomen with or without or whatever, it's defined a very specific way. And so when you go to send the data from your software, your system, it will be labeled the same as it goes into the National Dose Registry. We've actually talked a little bit about this during this in a couple of months ago. One free option for you to consider is you can go to RSNA. You can go to playbook.radlex.org. In fact, we've actually talked quite a bit about this a couple of years ago when I was physically in Thailand. And I know you guys have adopted this in Thailand. For those of you that have not or have not had experience with this, you go to this website, it's free. You can download all this, you can look at all this. It comes in spreadsheets, but you can go in and you can look at different ways to identify the data internally and then identify it through the National Dose Registry. And then it will be, so in one label, so this RPID, it's labeled RPID2, and that would be any CT abdominal angio with or without contrast. And so anything that meets that criteria, some abdominal angio with or without, it would be labeled as an RPID2 as it goes into the National Dose Registry. All right, so we just kind of talked about that, but you need to develop something. Radlex is a great way to start. Even if that's not what you ultimately use, I would recommend go to their website and at least understand how they've established it. So just a quick overview of what we talked about. You got to get data out of your scanner. You need to get it into your software such that it's either from PACS or your dose reporting structure software, whatever, so that it gets into a server that's on your site that prepares that data. Excuse me. It maps the names, it anonymizes things appropriately, and it pushes it to the National Dose Registry. In our case, as this is an example of the US, we use the ACR. So it goes up to the ACR's, their server. They do a bunch of analysis and data calculations. And then, like I said, quarterly, we get a report back to our hospital. So this is kind of just the ecosystem, that full circle that hopefully this data will go through at each one of your hospitals. So we talked about how it needs to be anonymized. There needs to be some kind of reporting structure so that the hospitals can use that data to actually make sense of it. It's one thing to create DRLs. It's another thing to create DRLs that can then be used for quality control. All right. So that's everything I have for this talk.
Thank you so much, Sam. But you still have another talk about how to interpretation, right?
Yep. Got one more talk.
Okay. Yeah. So I think we can go for the next talk, and we have at the end for the questions. Mm-hmm.
Yep.
It's gonna be a long night for you.
All right. Here we go.
Okay.
Session 23. It's been a long time. I'm sure you're all sick of me by now. Just a quick reminder. We talked at length about this publication at the very beginning of this IAEA mission. So 3 months ago, I still highly recommend you guys go download ICRP publication 135. It's on diagnostic reference levels. It's how to set them up, and most of everything we've talked about, I've tried to take from this document. It's been kind of my guiding it's been my guiding light in helping prepare everything I've done so that you guys have a structured way, where we've talked about the metrics, the naming conventions, how we set it all up, what we're about to talk about now, all of that comes from that document. So if you ever get confused with what I say, just go back to that IAEA document. So real quick, just a quick review. We've said this 100 times over, but what is a DRL? So let's go over that one last time. They're great practical tools. They're used for us here in the radiology and interventional world. They help us to establish a goal of what we would consider an achievable diagnostic task from an image. So if nationally speaking, you have one protocol, let's just say the CT of the chest, a routine CT of the chest, and you have a national dose level of certain milligray. Let's say it's 8 milligray. So it's a volume CTDI of 8 milligray. And you as a hospital are above that value, one would argue that you are using more radiation than is necessary. If you are below that number, you're using at or below what the average person in your country is using to make the exact same estimate. So DRLs do not directly define image quality, but what they do is they help us define a tolerance level that will be based on radiation dose that would help us understand if the image quality would be appropriate for the dose we're delivering. So I know it sounds a little confusing because DRLs don't define image quality, but DRLs define the dose that really should be adequate for the diagnostic task. So if the dose is adequate for the diagnostic task, then the image quality is most likely also adequate for the diagnostic task because dose and image quality are interlinked. So the objective of creating DRLs is to help avoid delivery of excessive radiation dose to the overall imaging population, and it helps give guidance to local hospitals based on national consensus data. So it's no more or nor less a estimate of how well everyone, on average, in Thailand or whatever country you're in, is doing. So if the entire country is using high doses, well, then the average is just high. And so that's why we've talked about consistently throughout this entire mission. It's one thing to create DRLs, but it's another thing. It's a good way to also make sure that those DRLs are accurate, or not accurate, but are in a good place by comparing to regional DRL. So compared to like countries surrounding you, maybe Korea, Japan, China, India. You can compare it to Europe, America. You can compare it to whoever you really want. And we'll actually talk a little bit about that later, but it helps understand. So one thing to establish the DRL, and then just make sure those DRLs are reasonable. So what a DRL is not, is it's never to be applied to individual patients. It's never to be used as an actual limit for patient examination. And it is never meant to be punitive. In other words, we don't establish regulations saying no dose, no scan can exceed these values. Now, I already mentioned it doesn't ensure diagnostic confidence, but one would argue that if 75% of all the hospitals are satisfied at that dose level, then it should lend some confidence, some help to the idea that the image quality is okay. So once again, it does not directly ensure these two things, but we still use this as that threshold for dose. Yes, and it doesn't ensure proper acquisition technique factors. So you might actually be getting a dose that's lower than that, but you might be using the wrong KV for whatever reason. Let's say instead of doing maybe you got your KV set too low. So the dose might be low, but the image quality might not be so great. So like I said, we talked about it at the very beginning that in a perfect world, you track your image quality with your dose. For national DRLs, of course, we don't focus on the image quality portion, but I would argue internally, you should always be asking the question, as a hospital, are the doses that I'm using to acquire these images, are they, obviously compared to the DRLs, are they adequate? Okay, now tell me, is the image quality sufficient for the radiologist's need? So what do DRLs provide? They provide a context to compare examination doses. And so like we mentioned, you can start comparing these locally, regionally, nationally, and once you have established DRLs, maybe compare them internationally. They are great for helping identify trends so that you can do a root cause analysis or an RCA. You can find where your doses are too low and you can find where your doses are too high. We've said this over and over again, but the DRL, the national DRL is set at 75 percentile. And then there is another level called the AD or the achievable dose, which is set at the 50th percentile, the true median. This idea that DRLs are set at 75, but once you're below the 75th percentile, the next goal is to work towards the AD or the 50th percentile. And it's just an attempt to continue to improve your image quality and your dose beyond the fact that you're now better or below the national DRL. So we've talked a little bit about what examination types we should assess. There's always going to be a priority because there are some imaging protocols or exams that we do that are very common. So the ones that are used all over the place, those are the ones we should definitely track. And of course, there's some out there that are just much higher dose. And those ones we should track, even if they're not that popular, just because they have the potential to do more harm. There are some that we would still want to collect, but we put them or categorize them as lower priority. These are ones that we won't worry about on the first pass. The first pass, we might take our top 10 CT scans protocols, but we might not in any way care about the musculoskeletal. We might not care about doing a forearm or a shoulder or something. They're very low risk typically, and they're typically low volume, as in low numbers of patients getting these studies. But ultimately, we would like to help establish DRLs for everything. So we prioritize our examination types, and eventually we come back and we collect data on the lower priority ones. All right, so that ICRP report that the IAEA uses actually established a list. We've already gone over this in the past, so I'm not going to read through it all again. But, example, mammography, should you have a DRL? The answer is yes. And then CT, et cetera, et cetera, et cetera. And so I put them here so you can look at the PDFs, or you can take this and just pause it and read through it if you want, or go back to our original presentation several months ago where we talked about these all at greater detail. But the reality is these are the ones that you should really start with, and then you can work your way down and create DRL specific to the examinations and procedures. You need to make sure that they're like for like. So it's one thing to pick a CT head, but it's another thing to do a specific, like a routine brain, because there's routine brain, there's brain shunts, imaging for shunts, there's imaging for a whole lot of different approaches. So you need to make sure you're comparing like for like, because one may be a higher dose, whereas if you're looking at shunts, those tend to be low dose neuroimaging and CT. You need to you need to make your comparisons based on technology. So some older systems will process things differently, therefore they may require more dose or less dose. Like the example I'm giving here in CT is you're going to have some systems that are older where they may be single slice. They might only use filter back projection compared to these newer systems with 320 or 640 slices that use deep learning and iterative reconstruction. To lump all that into one is not appropriate, but to separate those two is very, very helpful. We talked about naming conventions, so I'll skip over that. All right, what quantities do we use? We've said it 100 times now. Do not use effective dose. You only use quantities that you can measure. Since you cannot measure effective dose, we do not use effective dose. The IAEA recommends the following in radiography and dental to use air kerma. So it's the incident air kerma. It's not the surface dose air kerma. So this is just air kerma that you would measure at a point at the entrance surface of whatever organ. So in the body, it'd be the surface entrance into the head. I mean, the body, and the dentals will be the head. You can also collect it for CAP in mammography. And so the digital breast tomosynthesis, you should get the mean glandular dose, D sub G. Fluoroscopy, we've talked about, once again, the cumulative air kerma, but more specifically at the international reference point. You can also collect CAP data. CT, you get the volume CTDI and the DLP. Those are the two most common. We are releasing ours here in the US, the diagnostic reference levels for SSDE. So SSDE is just a quick reminder, corrects the volume CTDI based on the patient's size. And I think that's also very helpful because it helps flesh out the differences in patient populations that you're imaging. It's not currently recommended. The IAEA does not currently recommend the SSDE. I have a feeling in the future it probably will. Currently, they only recommend the volume CTDI and the dose length product. And then when you're doing stuff like nuclear medicine or PET, now we're talking more about how much dose we're putting into the body versus what the machines are putting out. So in this case, you just need to know what you're injecting. So the injected radiopharmaceutical dose of millicuries or megabecquerels. And usually we scale it by patient weight. Although you could just do straight up actual injected doses. So what you need to do here is that you're going to collect the quantities that are the most common, the ones that, of course, that you can measure, and you're going to calculate the median value and the mean value, and you're going to set the 75th and you're going to set the DRL at the 75th percentile, and you're going to do these calculations for every examination time. So just a quick reminder, why do we use the median value? Well, the median value is the literal middle value, the value where 50% of the data is on one side, 50% is on the other side. It is not skewed as much if the median value is not affected as much if you have a skew to your data. So in this example on the graphic on the right, you have a right-leaning skew. So you have a few really high doses and a majority low dose. So the mean in this case is going to move towards these higher doses because when you just do a simple average or mean, the high doses are going to pull that mean higher. Obviously, the word mode is just it's the value at the very peak or the center of the distribution. So when you look at the modes, of course, the modes are going to be highly different if you have two different distributions because the peaks are in different locations. The means are going to be different locations based on the shape of the distribution. So in this one, the purple values right here, they're right skewed, highly right skewed. So the mean is all the way out here. But these two distributions shown here, the purple and then the dashed purple and the solid purple, the green value, the median is the exact same. 50% of the data is on one side, 50% is on the other side. And so in this case, it doesn't matter what outliers you have, you can still calculate roughly the same value. And that's why we use the median to establish all of our statistics. So now let's just kind of talk a little bit as, once again, this is all refresher before we get into the discussion, what we should do to include in our DRLs. And so what you need to do as a hospital, you need to establish a team. We've already kind of talked about who to include in that team. What they need to do is they need to investigate the values that they get. So the national DRLs come back to the hospital. They look at their protocols that have been labeled, and they ask themselves, is the appropriateness of the protocol, are they using the protocol appropriately? Maybe they're overusing it, or maybe even underusing it in some ways. You need to review the equipment performance. Is the equipment adequately calibrated? Is it being tested properly? Is it used properly? Do the technologists have their adequate training to use it properly? Are the setting acquisition techniques right? Is the right KV used, MA, rotation time for CT, and then for everything else, the actual on time or the MAS. And these are ways to, and then of course I say image quality, because ultimately if the dose is too high or too low, if the image quality is good, that's one thing. If the image quality is bad, it's another thing to make all these adjustments. But we use these as kind of a way to compare our protocol. So in this example, a chest PA, I look at my hospital chest PAs and I compare it to the national DRL. And of course, this is Thai data. So in their case, it's 0.31 milligray. And so then I can go through with my investigation team and make these simple assessments, try to determine if we need to adjust our chest PA dose values. Do we want to move them down? Or, heaven forbid, we might actually need to move them up because they're too low. All right, so a couple of different scenarios are, if the hospital median value is much, much less than the DRL, what should you do? Well, you investigate the image quality. And then after the initial investigation and potential corrective actions, follow up and do the process again. Review it, make sure the doses are still in a good place. And you keep doing this over time to make sure that the image quality stays consistent for the radiologist, but also just with time, you buy new CT scanners, you buy new X-ray machines, and they all need new calculations, and some of them come with new fancy software for reconstruction. And you need to be able to make sure the protocols stay properly optimized so that the dose values and the image quality stay where they're supposed to be. All right. So what happens if you're below the DRL, but you're not really below? You're maybe close to it or just a little bit below. So now the question is there room for us to optimize these images? We're below the DRL, so we're not necessarily worried too much that we're overdosing per se. But we look at our image quality and then we ask, is there a way for us to reduce it more? Or is this the best we should do and we should not change the image quality at all? Or the dose, I should say. And you will still look at it, but you may realize that there is no change necessary. And that's just one of those things you file away and then you come back to it maybe in a year or two and revisit it when you compare your dose numbers to your DRLs again. The primary focus for any value, any protocol that has, or any exam that has doses less than the DRL, the primary focus should be making sure the image quality is where it's at and appropriate. If you do choose to continue to reduce the dose, it should always be based on image quality based assessments. So the DRLs help us standardize an acceptable level for radiation dose in a medical population. The actual total dose burden of the population is a completely separate survey. And we actually talked a little bit about this, especially when we were talking about CT. You guys are collecting data right now. You're using that to calculate DRLs. And in the near future, you guys are going to you're going to get software established all throughout the country, and you're going to get a wealth of data. This data is going to be flowing in consistently. And the question then becomes, can you do more with it than just simply establishing a DRL? Can you make a better assessment of the actual total population dose burden? So with all the statistics you're getting, you can start to now ask that question on it for a select number of exams. What is the average number of exams for, say chest PA performed at all the different hospitals and imaging clinics throughout Thailand or whatever country you're living in? And then how do those average dose values apply to that number? Or excuse me, not how, but you can then apply those numbers. So once you get a population size, so let's say you're doing a couple million PAs a year, chest PAs a year. Well, you know what the median values are from those hospitals you have surveyed. So now you can do some simple math, and you can actually start to calculate effective doses and population collective doses. So like I said, I gave you this example back in CT, and it's helpful once again to understand your population dose burden, to know what is the percentage is being used for modality and what is the overall effective dose in those modalities. So it's not necessarily meant, this is not for DRLs, but this is meant to just help guide and steer you as a country as to the usage of your medical imaging as a function of the dose burden to the population. So Tanya, of the few things she asked me to do for today, is she asked me to review how you would do this if you've never done this before. So obviously Thailand's kind of gone through this process once, but she wanted me to put these slides together kind of from the perspective of maybe some of our friends that are here from different countries surrounding Thailand, or whoever else that is watching in on this. So that was why we went through a very generic discussion of the softwares, the generic discussion of setting up a national dose registry, and the generic discussion of DRLs. That was just a quick review for everyone, so everyone's on the same page. Now, specifically, the next slides are going to be, Tanya asked me to go back over all of my talks and look for all the times where I made the comment, these are my suggestions. So now we're going to kind of go into each of the modalities, and let's just talk. There weren't, a lot. You guys are doing, so specifically in Thailand, you guys are doing a great job. You've gone through, you've collected a lot of initial data. There were just a few comments here and there that I had. So I'm simply just reproducing those comments now in these slides. And that will be a way to review all of the comments that we have talked about. And then at the end, I guess we can just talk about it. So in CT, obviously, here's your examples here. Some of the comments that I had made was to actually start the next round to start differentiating your data for pediatrics. And I know that's difficult. Here in the US, we're only now barely publishing pediatric data. We've had adult data now for over 10 years. We are about to publish pediatric data. So it takes a while. I get it. It's hard because you have to break it down to different age and size categories. We are here in the US, we've started collecting for SSDE. As I mentioned, the IAEA doesn't necessarily recommend it yet, so I leave that to you, but I highly recommend doing SSDE. It's just with the dose software, in CT, the dose reporting software easily calculates SSDE now. So it's just something that is going forward. It's a new metric that we are going to be using everywhere. In the next couple of years, you're going to start seeing SSDE on all of your CT scanners. The IEC is moving forward with that. It's been working on that for probably about 10 years now. So it takes a while to make these changes, but once they happen, and they stick for a long time. And we talked about dual energy CT. Dual energy CT is right now is a pretty small fraction of what we're dealing with in the overall CT population. But dual energy CT has become very popular, especially in adult imaging. All vendors pretty much have dual energy capable CT scanners. And there are some hospitals here in the US that they do all of their imaging with dual energy now. And so for what it's worth, I recommend that on your next round of CT, you ask that question and start to see if you can collect some data. Now, you may not collect enough data to do real good statistics, and that's okay. And you just might not do a lot of dual energy CT in Thailand. That's okay. But I would just recommend starting to consider that. All right. So in the IR world, the one big question I had was your units. So when you looked at all the numbers were great. Your values, your average was just, you were a little higher in some countries, a little lower than other countries compared across the world. But the issue is most people report DAP as gray centimeter squared. You guys use the units of milligray centimeter squared. So you are going to look into this because assuming your numbers, these numbers are actually gray centimeter squared, they line up real well with the international data. if they're actually milligrade centimeter square, you guys would be the lowest dose system country in the world. You guys would be all down here at the bottom of this graph. So that was just one thing that we wanted you to do, is just double check your units, which is basically what I said here at the top. But the other thing is, and this is not in any way meant to be a critique, but every country chose which IR procedures to report for their national DRLs. And you should do that specific to Thailand, because there may be specific protocols or procedures that are just very common to Thailand. I don't know why they would be unique to Thailand compared to, India, but maybe there are specific ones that you just do more of for whatever reason. And so that's why when we looked at the national data, international data, there were very few procedures. There were very few procedures out there that were common among all countries. But what I would recommend is you find the most common ones in your country, and it would be great if you could find one or two that are common across all countries as a way to try to calibrate your output values. And so that's just a way for you to know if, as a country, your interventional numbers are in line with the others. And as I mentioned, that was, right here, you can see here with the embolisms, aneurysms, you guys are a little lower than the average. Excuse me, stents right here, a little lower than the average, etc. So if you just find a couple of common ones, that's great. But then you may find some other that are very specific to Thailand. All right, we talked about the film screen, and in fact, Panruethai, she brought this out in her own data. So this isn't something that I'm necessarily pointing out. But when you look at the data, obviously the national DRLs, your film screen data is actually lower than your digital, which is actually should be the opposite. So that's one thing that you guys have hopefully been looking at. And the other thing to consider is the max-min ratios, where in general case, 8, 10, 16, 8, 10, 12, you see these are generally in the same ballpark. Going from 160 to 42 or 40, I mean, those are, it's 2, 3, 4 times different doses. And so looking at getting these ratios to be more consistent, and then obviously getting the doses on the digital lower than that of film screen. Excuse me. And obviously here, what you're trying to do is you need to look at your real extreme high values. Excuse me again, and your extremely low values. There may be that some cases are high, your max values over here for chest PA at 4.32. And this one is 0.42. Just the differences of the max values, and then the min values 0.05, and this is 0.03. So the mins are in line, but the max values in this case are way, 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 way high, way, way high in that one. Yeah. Oh, yeah. And then forgive me, I forgot to mention these two. I clicked my button too quick. We talked a little bit about, especially in DR, CR, all of these DRLs are specific to a point in space. You say entrance skin air kerma, which basically is going to roughly be somewhere at the surface of a patient. So you guys have defined that your patients are about 60 kilos, plus or minus 15 kilos. And that's perfect. That's great. So now you have a rough size of a 60 kilo patient. So there's a rough distance for where these DRLs are being calculated. So it'd be helpful when you publish this data. So when I, as a hospital, am comparing my numbers to your numbers, I know basically where my DRL is. So if it's a 60 kilo plus or minus 15 kilo patient, that patient might be on average, say 30 centimeters or 40 centimeters thick, or whatever, 60 centimeters, who knows? It's just whatever that is, so it's some distance from the table, maybe, or some distance from the x-ray tube to a point in space. So simply providing that as much as possible just helps hospitals know when they hand the data sheet over to their physicists, they can go, oh, yeah, I know, I make those measurements at that location. So that's why our data is the same. Or the data that you submitted may actually be, let's say it's higher, but you realize that you make your measurements higher than the national DRL. Of course, they're higher, closer to the X-ray tube. So of course your numbers are higher. And so you would scale them back to the point in space where the national DRLs were calculated so you can make sure you're comparing apples to apples. All right, we talked mammo. You guys are great. One of the things when you look at this, your DRLs are 2, 205, 206, 204, 201. So this is full field digital mammography. You got your right left CCs and your right MLOs, and that's great. But one of the comments I made when you actually look at the numbers, so now you look at the 25th percentile and the 75th percentile. So you calculate what's called the interquartile range. This will tell you what the spread of your data looks like. So here you see the actual 75th percentile. Those are all just, they look great. They're right lined up. But when you look at the IQR, you see here this right MLO is actually lower than the average. And that's why when you come and you look at the statistics now, the 25th percentile is actually higher. The median, the 50th percentile, is actually higher. And so you can see where as a national 75th percentile, everyone's kind of doing well at that level. But when you start to get at the lower end of the scale, you find that for whatever reason, the right, median, lateral oblique, sorry, I can't speak anymore. The right MLO, for whatever reason, tends to be higher, and the median value tends to be higher. And so there's a chance for you to maybe look at, obviously what this means is your data is skewed. And so you have the opportunity to, people see that, they go, okay, I'm lower than the DL, I'm at or lower than the national DRL. That's good. But then they can then look at their median values. And there's maybe some room in Thailand to figure out why the right MLO is a little bit higher than the left MLO. All right. And this is generally true for IQR. You can make these IQR calculations on anything, on these calculations over here, on your digital, on CT, on everything. And that's just a great way to find statistically if everything keeps lining up all the way from the lowest to the middle to the highest. So what were some other questions I asked about mammo? So you guys reported that you have 865 mammo machines. The question I had to you was what percentage of them were film? So you presented these numbers. Is that just a mix of digital and film? Is that all film? Is that all digital? I just don't know. Here in the US, we are 99% digital. So we don't even report film. And that's fine. I would just simply label this digital if that's the same as it is in Thailand. We talked a little bit about digital breast tomosynthesis and how that's becoming very common. In the US, we haven't got there yet. We need to establish DRLs for DBT. And that is because almost consistently, all of our patients are getting DBT and a full field digital mammography. So four view, right left CC, right left MLO, and then usually one DBT per breast. So we need to start collecting that data. That's what I just recommend you guys start doing. Yes, and then kind of like we talked about in X-ray, where in space are you making your calculation? In this case, you should report just an average breast thickness. So typically here in the US, our average is 4.2 centimeters. That's not our average. That's the value that we use to calculate our dose, our mean glandular dose. But when you do this survey, you may find that the compressed breast average is different than that. In fact, in the US, you may recall when I showed our data, our average is like 5.5 centimeters. So when we look at our national DRLs, it's actually to about a 5 centimeter breast, not a 4.2 centimeter breast. So providing those statistics helps people know when they start to compare their data if they're comparing apples to apples. And then if you have that data, it's great if you provide typical KV and MASs for those compressed, for that thick compressed breasts. And it's just a way that if someone's value is higher than the DRL, so their right CC, their craniocaudal, is higher than 2.05 milligray, well, what they can do then is they can simply look at their average, their typical protocol that they used, and they can compare it to those statistics and that compression thickness. And if they are substantially different in compression thickness, either A, they need to adjust how they're compressing, or B, for whatever reason, maybe they just have a population that's skewed higher or lower. If that's the case, that it is what it is. But if they can, they should improve their compression or improve their KV and MAS. And so it just gives them a way to make that first step into their quality control. All right, so let's just wrap all this up, last couple of slides, and then we'll move into the discussion. So futures, other areas that you guys can now start moving towards. You got your nuclear medicine, of course, but with that comes multimodality imaging. So now you've got CT scanners attached to PET scanners and SPECT scanners. And so you need to collect for both. And the way we use CT in nuclear medicine, of course, is very different, but it's helpful to collect that data too, because it is a percentage or a part of those protocols or those patient exams. You have been at this point, speaking of specifically to Thailand, you guys have been working on your high priority list. You've got your top 10 CTs and your top 10 DR and CR protocols. You've done your mammo, FFDM, either digital or film, whatever it is. You've kind of gone through that list that I already showed you from the ICRP report. So now you have a chance to start to go back and work on some of the low priority stuff. So now you have things like general fluoroscopy, stuff that dose-wise is never really high. So VCUGs, video swallows, stuff that is still good to optimize, but you just don't quite necessarily need to worry about it too much, because compared to a CT perfusion scan, you don't really have to worry too much about doses in general fluoro. Now, there are other ones out there that are just difficult, such as C-arms in a mobile C-arms, such as used in an OR or not an OR, surgery suite. So used in just general surgery or used in ortho. So that's just hard to collect, because usually those machines don't collect dose real well. They don't aggregate it well. They don't have good structured dose reporting. They're getting better, but they really just don't. And most people that operate those systems aren't always in radiology or from radiology. So you don't necessarily have the direct connection to your dose structure reports. Your dose reporting software. So now it's time to start working on these other low priorities, like in CT, face, orbits, etc. So what are some things we can do to help in those next steps? Obviously, you're going to get your software out. You're going to get it connected. That's really probably the next best thing you can do, is try to take the manual process out of this, get the software integrated and moving forward. That will really help you a lot. Obviously, we got that. All right, so now that you've collected the data, you're going to go on, you're going to establish the next level, the next rate, next collection cycle. I know you're on kind of the second collection cycle on some of these. You're circling back to the very first ones. I think you started with DR and CR, so now you're back there. You can start getting the data out to local groups, local hospitals, so they can start comparing their median values to the national DRLs and see how they need to start adjusting their data. Each local place really should start establishing alert levels so they can start monitoring their own data on their own systems. Obviously, especially once they have their own dose reporting software, this will help them really address and find their own weak spots and hotspots. And so that as time goes on, as you continue to send more data and you go for DRL 3.0, 4.0, 5.0, we're talking 10, 15 years down the road, the data is just is cleaner and better and looks nicer coming from these hospitals as it goes up to the national level, because they're constantly doing the cleanup at the local level before they even send it up to the national level. Whoops. So you guys have just made wonderful, strong progress in the development of DRL. It just really is amazing. From the very first time we met way back at the very beginning of 2019, when we started talking about this all the way back in 2018, I remember the very first time we sat down and talked, you guys shared with us some of your initial data from your first surveys in DR and CR and film and whatnot. And so it was just really awesome to see now that you have all of these modalities, you have national dose reference levels, you've set up your RADLEX, you've set up your common naming conventions, you've really gone through all this process. So now the next step is just to get this out to the local level. And I really am excited to see how those hospitals start to absorb this data and see when you go through the next cycle now to see if your DRLs are going to start to come, if they start coming down. So I commend you for all of your hard work. This is not a small task. It has taken you years and years and years. And so I commend you. That's all I have for this. And I guess now we can open up to just general discussion.
Wow. Thank you so much, Sam, for giving us a lot of comments and look at our data and tell us what is the next step that we should do. And this is a time for discussion. And this is the first time in the 12 weeks that we have the full team with us. So we have, finally, we have Napaphong with us, that he can talk and comment on things with us. And we also have Dr. Panruethai and Dr. Jiraporn that are going to talk with us. And also, we also have Dr. Vivathana or Dr. Neng, the president of Radiology Society of Thailand, Royal College of Radiologists of Thailand with us today. So let's start with, there is comments from Sam that talking about the data that we sent it to him. So อาจารย์ปาหรืออาจารย์โอ๊คมีอะไรจะคอมเมนต์ไหมคะกับตรงนั้น
First of all, I would like to thank Sam for your great contribution. Actually, I didn't come in as the commentator, but I watched most of the episode from somewhere because I hardly be home on Sunday. Basically, what we have learned from you is great, and with different modalities. And basically what we have done in terms of DRL, we will complete the interventional radiology this year. And for digital imaging, we start already and we'll collect the DR part, because now DR, we have more and more unit. And for mammography, I think 100% of the data we got is from digital, not the film. We no longer use film screen anymore. So that's the thing that we are currently doing. But for the next step, which is one of the biggest thing that will ever happen to Thailand, is the National Dose Index Registry, and I will share with everyone later about the current development. It's a little bit delayed. I got a nag from IAEA and asking about the progress, but because of the COVID pandemic, which is quite bad during the past month, we can't do much now in terms of the installation. But most of the plans are done. Like we have our LAX Thailand system to do the protocol naming, lead by Dr. Panruethai. It's done already. Now it's just the matter of connecting the hospital dose management system together and link to the data clearing center in Bangkok.
That's great. That's exciting. And I was talking to Tanya about, in the future, the opportunity of, for the next expert mission in the next year or two, it'll be wonderful to go back and see all of that data as it's flowing. And so, the next time we all talk about this, it's going to be to really review all of the data at a very large scale. because you guys are getting to that next big step where you can go beyond just doing DRLs to now you can start doing population estimates. And so it's really going to, once that software is established, you guys are really unlocking a key component to doing true data analysis on patient on population dosing. Dose from Thailand.
And on top of that, I think that the benefit from this DRL data collection is about optimization. And we do not have many of the clinical medical physicists around. And radiographers or technologists, we also have some limitation because of our education and training may not focus on this issue, unlike the clinical physicists. So I think training on optimization would be great deal to the practice in Thailand also. And especially after the DRL come out, I got a lot of phone calls from our radiologists saying, like, for example, head and neck CT protocol. The radiologist called me and said they cannot read the image because our technologists just focus on optimization. They look at the DRL and just decrease the dose without worrying about image quality and things like that. Again, we have to focus to them that DRL is not for individual patient, and this message must be spread around so that we have the same tools or the same way to exercise this mission to optimize the dose to our practice.
Yeah. And I commend you for that. That's not a small task.
ค่ะอาจารย์ปามีอะไรคอมเมนต์เพิ่มเติมไหมคะที่จะคุย
About the unit of the interventional, I think it is my fault.
Oh no. No one's fault.
About the unit, probably I put the milli. It is already gray, as you say.
Yeah. No, I'm sure it was.
And about the TACE of the body intervention, it is the liver. And about the digital radiograph, that the proportion of the maximum minimum, the Department of Science of the Public Health Ministry have the check the number, and it is some mistake, and for the chest they have another correct one. But for the others about the same. There's about 50 or around that the difference between minimum and maximum. But only the chest has changed down.
That's great.
The number is less than that.
That's great. So you're making good progress. It's moving the right direction. That's awesome.
And indeed, this year the Department of Medical Science going to do the cycle of the digital radiograph again. And in this year include the pediatric chest.
Oh, wonderful.
Hey Sam, there is a questions from chat box. So first one is about should each hospital send the total number of the examination in each protocol through the AOP?
So the answer is yes, that's a great statistic to have. It's part of, now you don't see the total number listed in the DRL, but for someone like Dr. Panruethai and her team, being able to understand the total it takes the data to a different level, because now, we talked a little bit about, I'm just going to get out of this view. It's easier to move this way. Actually, I'm sorry, I'm scrolling on the wrong one. But we talked about doing population dose burden, and I don't know where that talk went. But being able to know how many total, there it is, over here. Being able to understand this pie. So if you have a certain hospital, so you've picked your top 10 CT protocols, and you can give the dosing information, and Dr. Panruethai and everyone at the national level, they're going to do all the dose calculations, and they're going to provide the DRL spreadsheet or calculations. But then when you start to collect the total number, so let's say in a year, the average number is, I don't know, 10,000 or something, chest x-rays, pediatric chest x-rays at your institution. Well, now you start getting that data from all over Thailand. You can start putting together these types of pie charts. And then that shows you the overall dose burden. You know, we kind of mentioned way back at the beginning, in the US, the medical dose burden is about the same as our average background dose burden. It's about 3 millisieverts. But in Thailand, your national background dose level is very low. I think it was less than 1 millisievert. You just don't have a lot of natural background radiation. You guys all have probably nice, good skin complexions, all healthy people in Thailand, right? But so that means your overall medical dose burden is going to be much higher. And so you might be able to, but you really don't know that until you start doing some of these calculations. So getting that average is getting the total sample and population numbers is a great thing.
I believe that Dr. Vivatana, the president of the Royal College of Radiologists, is working on the survey of the frequencies of examinations in Thailand.
That's awesome. Yeah. And that's hard. Every about 10 years, we do that here in the US, and it takes probably 2 or 3 years worth of and it's a team of people collecting data, and there's no one source of data. So you have to we go to billing, we go to different surveys, we contact hospitals and ask them for that data. It takes a lot of different sources to try to estimate what your total population is. And so if you do have a way for all the hospitals to report their national dose values and start reporting their actual population totals, that goes a long way to help out. So that's great.
Yeah. On top of it, I think we need to submit the data to United Nations every 10 years. It's UNSCARE project. I think this is the same thing. But a big challenge to us is this statistics, because we don't have such mechanism to collect the data, like the frequency, how many examination in each modalities, and the age group of the population. Even the UNSCARE said that we can do estimate, but there are a lot of uncertainties in there. So, but however, we will try our best to send for the next round, which is 2028, I think.
One more question, Sam. So as you suggested that SSDE could be used to be another good dose matrix for CT. However, in some examination, such as cardiac CT or spine CT, where the reconstructed FOV is smaller than the actual body size, because when we are correcting the SSDE data from the software, they will automatically calculate the SSDE based on the body size extracted from the partial FOV, resulting in overestimate SSDE. So what should we do? Should we do like the full FOV and send the reconstruction and to the dose tracking software to correct this problem?
Mm-hmm. So 2 things here. The way that most dose reporting softwares do this is they actually calculate it based off of the scout view. And so when you send your data, your dose structured report to your software, usually you'll send also your scout image. And obviously, as you know, that when you do the scout image, usually you can see the whole skin. Yeah, you can see the whole skin length, the boundary from edge to edge. And so you can calculate and do SSD calculations off that. The other thing is, I would say, is in the future, as I mentioned, the IEC has gone out and has defined a way to calculate SSD for all CT scanners, all vendors. And so in the future, the scanner itself will calculate it. And so the dose monitoring software will simply receive that number. The software will not need to calculate that number in the future. So for the time being, if the software solution you choose does not receive a scout view or a planar radiograph from the CT, then it will be very hard, especially in this example that you provide. Because if you're doing a cardiac, you will do a normal exam scout so you can localize the heart, but then when you actually do the field of view, it's going to be truncated. The reality is you're obviously irradiating all of the material, all of the tissue around the heart. The whole chest is getting exposed, and so the SSD is still accurate. The CTDI the value is still accurate to the full volume. It's just if you try to make the measurement on the small field of view, your measurements would be wrong. So the software should be able to handle it accurately, and the software that you guys are using in Thailand will be accurate for that.
Yeah. So let's see if we have any other comments. Probably not. So we have Dr. Jiraporn here. อาจารย์ได้ยินไหมคะอาจารย์จิ
ได้ยินค่ะ
อาจารย์มีอะไรคอมเมนต์ไหมคะว่าfuture what is the future direction for Thailand, what are we going to do next, because this talk, I mean, like for the whole session, this is like a combine between the expert mission number 5 and 6, and actually you did it above and beyond, Sam. So this is like a maybe 2.5 expert mission. Yeah, it's like combined like a 2.5 expert mission together that we work for like a four months. So I would like to ask Dr. Jiraporn, after this one, and what is like the future direction for us? What are we going to do next, and what is our plans?
Yeah, I think for the past 5 years that we try to establish radiation dose safety for medical utilization and the radiation measurement and management. I think we have come quite far a long way from the beginning, as Sam had said. All this, we have to express our sincere thanks for the IAEA support, especially for Sam, who put a lot of effort to help us in establishing all this procedure, especially in diagnostic radiology. And we have gone through the several tests, I think, as a task force of radiation safety in medical utilization team under the OAP, and working close together with the IAEA. At present, as we have seen that we got a national DRL and a lot of and several data that can let us to have the standard value that we can optimize our utilization of radiation, ionizing radiation machine in medical use. And we also have established the National Data Center in trying to collect all the data for the nation, and that we can follow up with our procedure and data and everything that we have in exposing our population. I think the next step that, even though we have worked for 5 years already and with very hard work since 2018 up to now, it's about 3 years, but I think we just have started to come for about half the way, not about 25 or 30% of the starting point that we come. We still need to go and further make awareness of people who are in our field to alert and aware in safety use of radiation in Thailand, and try to establish the easy tool, just like the software, to help them collect the data for the whole nation. At present, we have most of the software tracking the dose and all those utilization in medical school and a big private hospital that they have to certify by the national standard. And only 9 software set for the government hospital or setting. But in reality, the government-owned hospital, they serve for about 70% of radiation dose exposure for Thai population. I think we need to work hard on try to help them acquire the software to spread and use in our country for the national data and national hospital or setting. These are very quite important tasks because it need to get apply for the budget from the government. That is one of our major force that we need to do. At the same time, as Sam had mentioned, details of the data that we have, we need to adjust, and then we have to go deeper and make full utilization of the data to allow us to use ionizing radiation more safely for Thai population. On this, on the behalf of Thailand Task Force in Radiation Safety Utilization for Medical Use, I really would like to express our group, our Thai people or Thai Task Force group for Sam in working very, very hard to educate us, to let us know how to start the way and walk along the way and go for the future one. For the 5 episodes of the lecture, I think it has laid down almost of the basic knowledge that we should know, we should learn. And we have recorded them to spread it out among our profession. And we're really looking forward to meet you. I think maybe by the end of this year or early next year, after we quite have enough vaccination for our nation and all of you from the US. And we think that we're going to meet in person and we go to the real workshop and analyze the data. Thank you very much, Sam. And looking forward to see you by the end of this year or early next year. Thank you.
Me too. Me too. Thank you very much.
Thank you so much, Sam. Naprapong keeps saying that I'm abusing you. I ask you too much to do stuff. But I said, because you are a really nice guy and you love to teach and you like to help Thai people.
As long as Nepapong as long as he's watching out for me and keeping me safe.
Yeah.
For the next time that you come to Thailand, you know, all those natural resources in Thailand, it has been revived and very, very beautiful because of the COVID. There's no mega tourists. So next time when you come, it's going to be gorgeous.
Yes.
Yeah. There is one comment on the chat box that refer to your lectures. So the most important persons are the one who expose radiation to patient and correct our data to national organization. So does it mean we should give them more knowledge and understanding both in university and workplace?
So, I appreciate that statement. It's not all the people on the top of the pyramid it's the people at the very bottom that make all of the actual decisions every day. It's like Nepapong said, it's the technologists that are the ones that are turning the knobs. And so, being able to disseminate as much of this information from the bottom up will make a big, big difference. It's all about the training at the university levels.
I do support Sam about this. I think RadTech school need to put all of this into their curriculum for the 4 years of their training, including the radiologists. I think that's one of the most important thing, education them when they are still young and they are not graduated yet. They have to I think they have to be stimulated and forced to learn about the safety.
And I think on top of that, from the school, which they can get all the basics, I think professional development is very important too. At the moment, the Thai Society of Radiological Technologists, we host the webinar at least twice a month online, and it's free to our member, and then they can collect the professional development credit. And part of it, we plan to do a lot of things about quality and safety in radiology also on top of another popular program. Like last week, we did open up the artificial intelligence school. We got like 500 registrants coming in to the program, and it's quite a lot compared to the number of technologists that we have. And I think the next program that we are looking at is going to be on top of this IAOC, which they have done a lot of great work by Tanya. We will focus more on the practical aspect, and Dr. Panruethai and our team, and especially the people from Ministry of Public Health, where they have people, they have access to the hospital. We already plan to run a lot of seminars about this, and this can help a lot with the knowledge for the technologists across the country, so that they know how to use the DRL. And it's under my work now that we have the guideline publication from the Ministry of Public Health on how to use the DRL. And it's going to be in Thai language. They sent to me like last month. I have no time to take care of it yet. So just remind me that I have to finalize this. It's going to be in Thai language, and it's going to be for the practitioner like technologists and radiologists, so that they know whatever information or the values that has been data collection and we published already about DRL, how can they use it? And like the first priority is that they need to understand that this is not for individual patient, and this is not the dose limit, things like that. So it's coming along, and we are committed to do. And again, have to thank Sam a lot, and also the IAEA that have such a good project like this. Again, Tanya, this mission is not 2.5, it's 5 missions combined together.
I totally agree. Yeah, I totally agree. 4 months lecture weekly. Yes. Yeah. So I think this come to the end of this mission. So there is a couple things before we're gonna take the group photo, because normally we usually take a group photo together. But since this is a virtual, so I'm gonna ask everyone to, let's see.
42 of us.
All of us, yeah. 40 of us, like turn on the camera, so we can take a group photo as like a last picture.
Yes.
For the mission. Let me see, how can I allow you guys?
You have to allow them. I think we need 2-3 photos, because I think we can get 20 people in one frame.
No, we can get 50 people in one frame.
Okay, good.
Yes.
You have to
do it fast.
Yeah, so my IT gonna do that part for us. So before we take the group photo as like the final shot. So please complete evaluation as usual, because we need to send that evaluation to the IAEA. And also we can improve our program, get things better. Please do the evaluation by the Thursday midnight, and on Friday you won't get any link. So we give you a break. For the IAOC. We're gonna give you a break for maybe 2 or 3 months to at least like get some rest and like a fight with COVID situation in Thailand. And in the meantime, if you have any questions or want to review the lectures, you can come back and watch on the Facebook Live that we have before. Our video is in there. And we also have the YouTube channel, Imaging Academic Outreach Center. So our lectures that Sam gave is in there. And we also have the PDF lectures in the website. So, but you need to like register to be the member before able to download the lectures, the PDF. So everyone, please turn on your camera so we can take a group photo together. And we're gonna end this session for the, as Napapong said, I agree, 5 expert mission in this year. 2 years, right? Past 2 years, then we don't have any expert mission. So please turn on your camera, and we're gonna end this session together with 3 acts. So first action gonna be yeah, and the second action, yep, gonna be like a mini heart. And what is the third one? What do you want to do? What do you guys want to do? Victory. Okay, yeah. So 3 actions, and we're gonna end this session. Sam, you have anything to say for us before we let you go? Have a good night.
It's been great. It's great. I'm going to sleep after 3 months now.
Okay, and we will see you by the end of this year or maybe next year. So please turn on the camera, everyone, and we're going to have this photo on the Facebook page, IAOC. So first action, yeah, so we are done. Yes. Okay, second action, mini heart, yeah. And the last one, thank you so much, everyone. We will see you again, maybe next year in person. Bye-bye. Have a good night, Sam. Bye-bye, everyone. คุณค่ะ สวัสดีค่ะ
สวัสดีค่ะ Goodbye, Sam. Thank you very much.
Bye, everyone.
Bye. Thank you so much, Sam. Have a good night.
Thank you.